Hello, my name is Stephanie Ernst, and I am the founder of TAP Support. But most importantly, though, I am a mother of TAPS twins born at 31 weeks in 2013. This has not been an easy journey, as we have faced a lot of unknowns about our diagnosis, and we rely on information that is available to us to support our girls and continue their long-term follow-up. However, what we do know is that over the past 12, almost 13 years, is that progress into TAPS research has been incredible, and we now know more than ever. So we are able to advocate for many things to ensure that our girls live life to the max. And all this is possible because 20 years ago, Twin Anaemia Polycythemia Sequence was given a name on the 3rd of March 2006. And dedicated researchers and doctors worldwide have made a lot of discoveries about our rare disease. So that's why it's important to recognize 20 years of TAPS research this year and to talk about where it started and where the future may take us. So this is my invitation to you to join us as we mark 20 years of TAPS and get involved in a year-long conversation about our rare disease. Visit International TAPS Day to learn more and be a part of 20 years of TAPS. Thank you.
Well, thank you very much, Stephanie. So that was a video to open the webinar today in celebration of the TAPS, the International TAPS Day, which is on the 3rd of March every year. So just welcome everyone. So good morning, good afternoon, good evening, depending on where you are. So welcome to the webinar today. The webinar is focusing on TAPS. My name is Asma Khalil. I'm a professor of maternal-fetal medicine. I work in the United Kingdom, and I am delighted to be joined by a team of amazing experts related to fetal therapy, for twin, for neonatal experts, for amazing Stephanie Ernst, the founder of the TAPS Support Foundation, who you heard from in this short video. I'd like to thank all of them for joining us today on the weekend to celebrate and raise awareness about TAPS before the TAPS Awareness Day or the International TAPS Day, which is happening in a couple of days. Again, to thank all the people who actually registered for the webinar today. We have more than 2,150 people registering, which is great. And really, again, many people who are regular attendants of our webinars. So thank you so much for joining us again. And also, of course, thank you for my team behind the scene who work really hard to make sure that these webinars are organized efficiently. Some housekeeping. So these webinars are recorded and you should be able to have access to the recording. They are available on the GEFOG Health Foundation website. It's a charity that we set up years ago. I think this webinar could also be available on the TAPS Support Foundation website. If you find that helpful. Again, we really want to raise awareness. We want to share the knowledge. We want to stimulate research in this area. We tend to mute all the delegates except the speakers to avoid any background noise. So please, if you want to communicate, use the chat box. Would love to hear from you. I personally always say I enjoy the discussion. That's my favorite part of the webinar. So please share with us your comments, your questions, your criticism. And also, of course, because these webinars are recorded, so if you turn on your camera, by definition, you have your identity or you have your name. Of course, the identity is revealed. The feedback, so we have at the end of the webinar, you will have the QR code. So please spare a few minutes to fill the feedback. Just let us know what you liked, what you didn't like, if you have any suggestions for future topics or sort of some suggestion how to improve. So I'm gonna stop here and invite the first speaker of the webinar today. And as I mentioned, Stephanie Ernst is not new to this webinar. She's a regular guest, a regular speaker, and it's lovely to have her again. And having worked with you, and personally, it's pleasure, always pleasure to have you joining us. So I'm gonna invite Stephanie to start the webinar today with her talk, talking us about Stephanie, about the TAPS, about her journey, about her babies, and tell us what we should be doing.
There's a couple of things I will talk about today. I think it's really important to start with, of course, who I am. But we're going to go through online communities, how patients can be involved in research, and also a little bit about myself so you can kind of understand where I come from and why I have this passion for what I do. So as we move to the next slide, this is a little bit about me. I am a parent of twins, first and foremost. I am a TAPS nerd out of necessity. My claim to fame is actually these lovely young ladies on the left-hand side are my daughters, and they were born, as I said, 31 weeks in 2013. They look a little different these days. That's actually a more recent photo on the right. They were in our family holiday last year to Salzburg. We went to the Science Museum. They had a lovely display about Christian Doppler and his work. So you can't go past taking a photo of them next to a display about MCA Doppler. On top of that, I'm a freelance content marketing specialist. I am an author. I'm a speaker about parents of twins and all the things we face. And I'm also an advocate. And I like to joke I'm a stay-at-home mum with a H index of 2. This is true. And also the fact that I founded TAP Support. I'm the vice chair of iCombo, and I have a couple of other hats working with the European Standards of Care for Newborn Health, and also more recently in Eurydice with the Newborn Screening Working Group. So that's a little bit about me. But my story actually begins, as I said, in 2013, and we fell pregnant after a loss at 12 weeks. About a year later, we kind of went for an ultrasound, found one baby. At 11 weeks, we found 2 babies. Needless to say, that 14-week echo was kind of touch and go. If they had found a third one, I probably would have passed out. And things actually went really quite well in our pregnancy. I did have hyperemesis, but this is just one of those things that is part of the pregnancy, and it was horrible. I don't recommend it. But at 24 weeks, I kind of started feeling a little bit bigger, and I had a backache, and everyone knows where this is leading, so I'm not going to make it a big dramatic story. Basically, within days of taking this photo and posting this Facebook status, I was diagnosed with TTS and taken from my local hospital to Leiden in the Netherlands, where I was diagnosed with stage 1 TTS, as well as this other thing they were looking at called TAPS. Now, I am one of the rare cases where the TTS just spontaneously resolved, but the TAPS actually progressed and it became worse. And at 31 weeks, my girls were born because they thought they saw a shadow on the brain of my recipient. This is my placenta. It's a very funny story. You can ask Enrico. But that photo of the girls that you see there, it's not the way that I like to remember them because it is a very traumatic time. And I actually talk about that this week in our awareness campaign. But this is the way I like to remember them, because after all the drama and everything, it was really lovely to be able to hold them and just know that everything was going to be okay. And since that time, basically what has happened is that it's really, because there hasn't been a lot of information about TAPS out there, it kind of was a driving force in me to sort of get out there and start talking about it. I was very lucky to make friends with the research team that looked after my girls. And since then, it's kind of been a really big collaboration, and we raise money together. We also work together. But my proudest moment in life, of course, is being a mum to these 2 fantastic girls. And when I go back to my story, I really feel like when I joined the communities online, they were very TTS focused and not about TAPS. There was nothing that was really specific to who I am or what I do. And then it kind of came on later as well, because within the long-term effects, both my girls have been diagnosed with autism, ADHD, DCD, and it impacts them both differently. And our biggest challenges have always been that they were born at 31 weeks, so they're very preterm. And a lot of our concerns were actually dismissed as routine prematurity related things. And we were actually discharged from the follow-up system at age 2 because prematurity ends at age 2 or not. And our local TTS, local hospital actually recorded us as TTS and not TAPS, even though we had very strong evidence that we were TAPS case, but our local hospital had that on. So it became very difficult to advocate for appropriate care and follow-ups. And the third thing, and this is possibly the most humiliating and frustrating and makes me very emotional even to say it now, is that having our concerns routinely dismissed because it's okay, mummy, you're overthinking things, or is this a real concern, or is it just something you read about? And these are very real things that are actually said to other TAPS parents, not just myself, but it has a significant impact on yourself and also your mental health. And this is a very quick slide. I just love this quote because there really is, you cannot be prepared for twins. I think when you are told you're having twins or multiples, it's a really overwhelming experience and you learn a whole new language. And people look online for other sources, and this is where I was going. And when you see online, the people that are online right now are very internet savvy. They know what they're doing. They know what they're looking for. They're looking for validation from peers. They grew up with the internet, so they know where to look, and they are looking for opinions on social media and all those kind of things. And so parents are really starting their journeys on social media platforms. However, it means that they can come to you with misinformation, or they can be anxious about what they read. And dismissing that can actually make you feel quite, can make patients feel really disconnected with you. Engaging with it, it kind of builds your credibility, but you can always guide patients towards peer, like evidence-based sources that are within their digital habits. And we know because we did research on this, and I'm not going to go through this slide too much, but we asked 2 questions when we did this research, and this is with two other monochorionic twin mums. We ran a survey back in 2021, and we asked people, how do you use social media during pregnancy, and how does it impact the decisions that you make? And our results were very clear. They also very much line up with social media, and this is something that you need to be conscious of if you are running any kind of campaign on social media. Your average respondent will be aged between 25 and 45. They will be female, they will be Caucasian, they will be highly educated, and they will have, they will have a fairly high middle to high income range. But they're looking at, when everyone joins online, they're looking for others with similar experiences. They want to learn about their pregnancies, and they want to get guidance from others. And so, 68% of people are actually using the social media to communicate during their pregnancies. And, more than half are actually saying that, around half are saying that social media impacts their pregnancies and how their management or their treatment options. But it's also, they're taking this information back, around half taking the information back and giving it to their providers and talking about it with them. And what's really lovely to see is that 70% of providers are actually listening and engaging with them and talking with them about it. Is it going to let me go to the next slide? Sorry, it just slowed down for a minute. And this is why, the reason why these online communities exist is because of the gaps of information. And if we go back to my story, I couldn't always relate to the stories that were in TTTS communities because they didn't match what I was experiencing. And it's not discrediting that TTS communities are not strong, because they are wonderful, they're strong, they're very uplifting. But when you have something that is not TTS, it's very, it can be a little bit isolating. And these online communities can give you real-time access to others with the same situation. You're getting peer guidance, and it's filling the gap too, because those every 2-week appointments, that's a long time. When you're in the parent world, it can feel like it's a long time. So talking with others about what you're experiencing is really good. And there are risks and benefits. I mean, it's not always evidence-based, and we need to really talk about that. Doesn't replace medical advice from providers. And there are negative stories, and people will come into these groups and say, I don't want negative stories, I only want to hear positive stories. But it also increases the emotional stress. But on the same side, it's bridging the gap. And there are really great evidence-based communities who are giving good information, supports patients to actually come back and say, hey, I wish I had have asked this. How do I ask this? And they can communicate a little bit better. And it can just be a really big help in making those critical decisions. And again, we published on this. This is peer support. And when you're looking at these peer support communities, there are good ones, there are bad ones, there are mediocre ones, but the good ones are always the ones that are evidence-based and have a good communication network with professionals. And they're also creating their own guidelines, their own boundaries, and they're complementing care as opposed to going against the traditional medical care. So, then when you're looking at these online communities, they're also a key partner in your research because they're the first point of contact for anyone who has a diagnosis. So if you're making connections with these communities, you're getting a really diverse, engaged range of people who can participate in your research and your studies. They can also help you understand the concerns and the barriers to care and, all these decision-making factors that come into when you're creating research. But they can also help increase the study rates because you've got a community that are willing to promote your research, talk about it, and get it out to the relevant participants. This is a really quick slide. I'm not going to go through clinical trial regulations. This is my day job, by the way. But the relevance is that within future research and right now, the guidelines are changing and patients have to be involved. And that's from conceptualization to the day you close the trial and publish everything. You need to have them involved in every process, and your investigators and audits are going to be looking for this. So key takeaways that I think just to talk about here, online communities are here to stay. They're not going anywhere. So guide patients to the good ones and don't discourage participation. Don't dismiss what they read in line, engage with it, talk about it, address their concerns, and look at the evidence-based alternatives in the language that they're comfortable with. Patient and organizations can actually help you improve your care because they can strengthen those shared decision-making moments. They can support your research, and co-designed research means that your research is always more relevant to patients and what they want the outcomes to be. One big question before I launch into a little bit of shameless self-promotion here. Google is not a reliable source. However, don't tell patients not to Google because my experience is that they will just walk out the door and they will go and Google. Ask your patients what they've Googled recently, and most importantly, Dr. Google is being replaced by Dr. ChatGPT. This is a really important one. Ask them what they've asked and what they need help with explaining, but don't dismiss anything they bring to you. And now, 5 seconds of promotion. TAP Support, we are an internationally focused organization. We've been around since 2020 as a registered charity, but honestly, we started in 2017 with 10 members in a Facebook group. We now have 1,300. And we raise money for research. Our latest tally was 35,000 euros, but our accountant is working on the latest figures and will tell me next week. Our biggest push is that we want to provide the voice of patients and parents to research, but also support researchers in creating better research and get that to better outcomes. And we particularly like people from low middle income countries, early career researchers to support them as well. But we also like to build communities. We have a range of stuff on our a website that you can look at. We are also very much focused on evidence-based. This is why I have such a big thing. This is just a little bit of the work that we have done and presented. But our community is the most important thing to us. And that is, we want to build bridges between people, but not only patients, with research teams, with other organizations. We are very much about connecting and helping and sharing. And this makes me so proud to see all the people on here. And I know all these families, and also our twin day, our twin run, they're all on there. We mentioned 20 years of TAPS. Please visit internationaltapsday.com. I promise there's 3 more slides and all of them are 2 seconds. On March 3rd as well, we are launching a children's book about TAPS. And this is actually a physical copy of it. It is a book that is really about explaining TAPS to children, the children aged 5 to 10, but that sweet spot of 7 to 8-year-olds who are asking a lot of questions. As a parent of TAPS twins who have been 7 and 8 years old, they do ask a lot of questions. And this is really creating something that gives conversations. And if I can give one key takeaway from this, we need to change the language around TAPS. It is not a form of TTS. We need to change this because, number one, it dilutes the urgency of updating screening protocols and also encouraging more research. But for parents like myself who have an incorrect diagnosis on their paperwork, it makes it harder for us to get the right follow-ups and the right care. And we were very fortunate because we were actually still in a long-term follow-up program. So we were able to still get information that could feed on, but it's really important that we use the right language. big thank you to the TAP Support Foundation and the community around it, because they are the ones who support me. Also, the LMSA fetal therapy team who support me and listen to my crazy ideas. And of course, any illustrations you saw in there are by the amazing Amanda Gauthier. And we work together also on the book, but also a big thank you to Asma and GEFOG and the Twin Multiple Pregnancy Academy for always having me here. You can email me, Stephanie@tapsupport.com. You can also find me on LinkedIn. But big thank you to the two young ladies in that photograph, because they are the reason why I do what I do. Thank you.
Great. Well, thank you very much, Stephanie. It's always personally as a pleasure for me when I hear a member of the public saying we need more research, because it's a really strong incentive for the researchers to actually keep going and trying to answer the questions and produce robust research. So lovely. And in terms of the online communities, I think that's great. And I think that the healthcare professionals, I mean, most of the people attending today are healthcare professionals. I think it's important that we understand where the patients get their information from. And certainly that's already sort of happening. So I think it's really nice of you to actually highlight us what we should be doing. I'm sure there'll be questions, but I'm just conscious of the time. We've got already busy program and we've got a number of talks. So we're gonna get on and present the next speaker. And that's a really nice introduction to the research. So we're going to start the webinar or sort of with obviously the voice, the patient voice, and then we follow with the most recent research on TAPS. And it's my pleasure to have Dr. Alex from the United States, Alex Forrest, who is going to present some of the latest research about the TAPS and the response to transfusions. Alex works in Johns Hopkins in the United States, and her mentor, Professor Ahmed Bashar, is here with us. So thank you very much for joining us. So please go ahead, share your screen and tell us about your research.
Wonderful. Well, thank you so much for having us. As mentioned, my name is Alex Forrest, and I'm a maternal-fetal medicine fellow at Johns Hopkins in Baltimore, Maryland. I am really looking forward to presenting our research today in collaboration with the Center for Fetal Therapy on the fetal hematologic profile in monochorionic twins with TAPS undergoing serial transfusion and partial exchange. We were really grateful that this work was recently featured at the Society for Maternal-Fetal Medicine annual pregnancy meeting in Las Vegas, where we had an oral presentation and an award as recognized by the Kate and Paul Foundation. So thanks so much. So I'll start with some background that most members of this audience are familiar with. As we all know, monochorionic twins are unique because of their shared placental circulation. This places them at risk for complications arising from intertwin vascular connections. And Twin Anaemia Polycythemia Sequence, or TAPS, is a distinct subform of twin transfusion syndromes that's proposed to be the result of the chronic passage of red cells across small placental anastomoses. The clinical picture that results is that one twin, the recipient, is polycythemic, and the other twin, the donor, is anemic. The hallmark diagnostic criteria for TAPS are based on MCA Doppler peak systolic velocities, where we typically observe suppressed velocities in the recipient and increased velocities in the donor. The diagnosis of TAPS can be particularly challenging as it can coexist with TTTS or be isolated. And so the typical signs of hyper and hypovolemia that are seen in TTTS are not always present in TAPS. Further making this diagnosis challenging is the fact that TAPS tends to present over a wider gestational age window and often later in pregnancy. There are several other ultrasound findings in addition to MCA Doppler changes that have been described in TAPS, and these include a starry sky liver in 60% of recipients, unequal placental echogenicities between twins, and fetal growth restriction in 40% of donors. As mentioned, TAPS is a relatively recently described clinical phenomenon, and so the underlying hematologic parameters and how they correlate with the ultrasound features we see non-invasively has not been well described. And so this motivated our study. We created a study specifically aiming to characterize the hematologic profile of spontaneous TAPS and its response to serial transfusion therapy. This was a single center retrospective cohort study conducted at the Johns Hopkins Center for Fetal Therapy from May 2016 to July 2025. Patients were specifically eligible for enrollment if they presented with persistent stage 2 or greater TAPS and underwent serial transfusion and partial exchange for management. In our center, patients are offered this management strategy when they present with an MCA peak systolic velocity discordance greater than 0.7 MOMs as based on the 2019 Tolinar criteria, if they are not a candidate for fetoscopic laser surgery or selective reduction, and if they're below our gestational age, that would be our threshold for delivery. Our primary outcome of interest was the hematologic parameters at the time of initial blood sampling prior to any fetal therapy occurring. This included fetal hemoglobin, hematocrit, reticulocytes, platelets, and immature platelets. Secondary outcomes of interest included MCA Dopplers and their correlation with the hematologic parameters, as well as the hematologic response to serial transfusion-based therapy. We hypothesized that donors would present with anemia and upregulation of their reticulocyte or red cell precursors, and conversely, recipients would have polycythemia with reticulocyte suppression. Secondarily, we hypothesized that these abnormalities would respond to serial transfusion and partial exchange. Our center has previously published on our approach to transfusion and partial exchange for the management of TAPS. We typically perform these procedures on our labor and delivery unit with a double setup that mirrors that used for transfusion of an anemic singleton. We always turn our attention first to the anemic baby when we perform a transfusion, and then the polycythemic baby where an exchange is performed if indicated. We use bedside testing for real-time clinical application, and then the remainder of the sample is sent to the lab where additional testing, including complete blood count, can be performed and help to facilitate some of the parameters analyzed in this study. It's important, though, to recognize that the fetal response to a transfusion is distinctly different than that to a partial exchange. In a transfusion, there's typically an almost linear and predictable increase in fetal hemoglobin. Alternatively, this is not the case in a partial exchange. In an exchange, over the course of one procedure, blood is serially removed and replaced with saline to avoid the significant hemodynamic shifts that can occur with removal of large volumes. The result is that the blood becomes dilute, and there is subsequently a nonlinear drop for the same aliquot of removed blood. Thus, partial exchange is inherently a less efficient procedure than a fetal transfusion. So I'll next orient you to our study cohort and the procedural characteristics. We enrolled a total of 11 pregnancies with stage 2 spontaneous TAPS of a total of 150 TAPS referrals to our center. The median gestational age at the time of first fetal intervention was 27 weeks and 3 days. We obtained a total of 150 blood samples, performed over a median 8 procedures per pregnancy, and the median interval between procedures was 8 days in our cohort. The gestational age at delivery was a median of 32 weeks and 3 days, representing a meaningful pregnancy prolongation of 35 days. In our cohort, 45% of patients delivered between 32 and 34 weeks, the expected delivery timing for complicated monochorionic twins. We'll first take a look at the Doppler and hematologic profiles at the time of initial blood sampling before any fetal therapy had occurred. I'll draw your attention to the MCA Dopplers. We saw a significant discordance between recipients and donors, as would be expected. Recipients clustered with an MCA at 0.8 MOMs and donors with one at 1.8. And this corresponded with a meaningful separation in red cell mass at the time of initial blood sampling. We saw that recipients had a median hemoglobin of 19.4 and donors one of 5.0 prior to any fetal therapy occurring. In this slide, we examine the correlation between the MCA Doppler and the fetal hemoglobin at the time of initial and subsequent procedures. The x-axis represents the MCA Doppler as expressed in MOMs, and the y-axis the fetal hemoglobin. We saw a strong correlation between the two at the time of initial blood sampling, and this persisted at the time of serial procedures. Interestingly, it remained particularly strong among polycythemic twins. The colored boxes here represent true positives. We saw that in polycythemic twins, as defined by an MCA less than 1 and a fetal hemoglobin greater than 18, there's a high test accuracy of 91%. Similarly, in anemic twins, as defined by an MCA greater than 1.5 and a fetal hemoglobin less than 10, the test accuracy was 87%. It's important to note that the relationship between the MCA Doppler and fetal anemia has been well established in Rh disease, but there have been questions that have remained about the reliability in the setting of polycythemia. The strong test accuracy in this cohort for polycythemic twins is therefore particularly notable. We'll next turn our attention to the hematologic parameter at the time of initial blood sampling for several other hematologic parameters. I'll first draw your attention on this slide to the reticulocyte fraction. This is the representative of early hematopoietic activity and is red cell precursors. We saw a significant difference between donors and recipients, where donors had upregulation of activity with a value of 25 and recipients comparatively lower at 7.4. What's interesting to note is this value of 7.4 is actually within normal range. In the setting of true suppression, we would have expected a value less than 1. So despite the fact that there is significant polycythemia at the time of initial blood sampling, recipients have a normal reticulocyte fraction. Similarly, the immature reticulocyte fraction is a marker of the very earliest red cell precursors, and we also saw a difference in donors and recipients. Donors had an elevated value of 18.7 and recipients comparatively lower at 11, but again, not completely suppressed despite their polycythemia. We also examined the platelet lineage and found significant differences, whereby donors had low platelets at 154 and recipients comparatively normal platelets at 219. The immature platelet fraction, representing platelet precursors, was also different between twins, with donors having an elevated value of 5.6 and recipients comparatively lower at 3.8. We next examine longitudinal trends during serial transfusion therapy. On this slide, I'll show you 3 graphs that represent differing hematologic parameters and the value that we saw at the opening sample of the first 5 fetal procedures. In this first graph, we look at the opening hemoglobin, and we see that donors in the red line have an uptrend in their hemoglobin, representing an appropriate response to transfusion-based therapy. Interestingly, recipients have a slowly uptrending line as well, reflecting the fact that partial exchange is not as effective at addressing the underlying hematologic differences as serial transfusion is. We also examined the hemoglobin discordance across serial procedures and saw that it was relatively stable over time, indicating that serial transfusion-based therapy is required and acts as more of a temporizing strategy as opposed to treatment of the underlying pathophysiology. When we look at reticulocyte percentage, again, a marker of early hematopoietic activity, we see that over procedures, as donor anemia is corrected, there's a downslope in the line. Interestingly, recipients also have a downslope in the line, despite the fact that they have persistent polycythemia. We see a similar picture when we take a look at immature reticulocyte percentage. Again, donors are represented in the red line here, and we see that as donor anemia is addressed, their early hematopoietic precursors have an appropriate downregulation. Again, recipients in purple here have an almost parallel line and downregulation activity despite the removal of red cell mass at the time of each procedure. So we see a clear difference between donors and recipients in their distinct hematologic profiles. Donors have anemia, whereas recipients have polycythemia. In response to this, we see an upregulation in reticulocyte fraction and a comparatively lower value in recipients. We also noted that donors had upregulation of platelet precursors, whereas recipients had comparatively lower, though often still normal values. We see as well that this extends to mature platelets in the difference between the twins. So this points to a picture of active compensatory hematopoiesis in donor twins and relative, though often incomplete, hematopoietic suppression in recipients. Now, the reasons for this are not entirely clear and require further study, but potential mechanistic explanation could be either reticulocyte or EPO transfusion across placental anastomoses between twins. So in summary, the MCA Doppler is an effective screening tool for TAPS, and values less than 1 MOM may be especially reliable for detecting recipient polycythemia. Spontaneous TAPS is associated with an asymmetry in fetal hematopoiesis, such that donors have active erythropoiesis with associated thrombocytopenia, and recipients have a relative erythropoietic suppression that is often incomplete. We note that the hematologic findings in TAPS extend beyond red cell imbalance alone to involve red cell precursors, platelets, and platelet precursors. We also note that serial transfusion-based therapy effectively corrects donor anemia and allows for meaningful pregnancy prolongation in appropriately selected cases. The optimal treatment with transfusion alone versus transfusion with partial exchange does require further study, hopefully harnessing the power of multiple institutions. I'd like to finish out my talk by thanking the members of the Johns Hopkins Center for Fetal Therapy, including all of our physicians, sonographers, nurses, and the patients and families who make this work possible. Thanks so much for your time. And if we have time for questions now, I'd be happy to take them.
Well, thank you very much, Alex. Very nice data. And I'm sure we will have, I already have a lot of questions, but just because we have also panel discussion at the end. So, and I think some of the things that you have highlighted also will feed into some of the discussion or the controversies about the diagnostic criteria, about also what the ideal management, the role of the partial exchange transfusion, which I think is really not fully established. And so anyway, I think we'll have a lot of discussion, but thank you very much. That was beautiful. We're going to move on with the next speaker, and it's my pleasure to introduce Professor Jena Miller. Again, Gina is not new to these webinars, and she has contributed on several occasions to our twin webinars before. And Gina was actually a member of obviously the Johns Hopkins team, and now she has moved to a new unit, which I think is TROP, correct? Which is another major fetal therapy in the United States. So Gina has prepared for us beautiful cases. So we always enjoy the case discussion. So look forward to seeing what you're going to present.
Okay, does that still look correct?
Perfect.
All right, fantastic. So for a very simple start, I also would like to support Stephanie's statement that that TAPS is a distinct entity from TTTS. And so I'll just share with you this simple case that we did have at Johns Hopkins. So this first one is just a 28-year-old patient, gravida 3, who presented to us at 18 weeks gestation. So quite early comparatively when traditionally people think about TAPS. And she was referred specifically for evaluation for TAPS. And as you can see here, this was the first, the representative images that we saw. So our recipient is always labeled A, our donor always B. And you can see with that little wisp of the membrane between that there's no difference in amniotic fluid volume, so very concordant fluid, but you can see the other features that are typically described of the discordant echogenicity in the placenta, as well as that starry sky liver and a normal appearing liver of the donor. There was significant difference in the MCA peak systolic velocity for the twins, and so we were convinced that the diagnosis was TAPS. And so in this particular case, where we can see exactly where we anticipate that equator between the two twins, we proceeded with laser surgery. And so after that, we saw a very nice response in the MCA peak systolic velocity after treatment, and confirming resolution of the condition and ongoing continuation of the pregnancy. So we dream that every case of TAPS is like this, but we know that that is not the case. So next I'll move on. That highlights some of the work that Alex has done. So this case is a 30-year-old prima gravida, 28 weeks and 1 day. She was also sent for a diagnosis of TAPS stage 2, and we could see there's significant difference in the MCA peak systolic velocity with a delta of 1.3 between the twins. So our donor had an MCA of 2 and our recipient 0.7. Based on the gestational age and where everything was located in the placenta, the other features that we saw that you can see here that we have a posterior placenta. And because of this gestational age and placenta location, it was actually quite difficult to appreciate difference in the echogenicity. But what you can appreciate here is that difference in placental thickness. So our donor had a very thick placenta compared to the recipient that was quite thin. And the difference in the liver echogenicity was also relatively subtle between these two twins. But if you look closely, you can see that the one on the left represents our recipient. So in this case, we proceeded with serial transfusions and exchange transfusions. And what was interesting in this case is that every subsequent transfusion from the experience that we had, with Alex's data, that we typically would see that increase progressively over time for our donor. But in this case, every week, the donor was just so severely anemic, again, down between 5 and 6. Also important to recognize that there are no signs of hydrops on this fetus at this hemoglobin level. Each time we were able to successfully correct the anemia, and before each transfusion, we did have a spike in the MCA peak systolic velocity again. For our recipients, very similar trend as you saw from Alex, that with exchange, we gradually brought down that hemoglobin each time, but it did rebound, and that trend was relatively stable. At the time of birth, that shortly after that last transfusion, the hemoglobin was 11.5 for our donor and 18.7 for our recipient. For the postnatal course, they were born that day, actually after their last procedure, and they were similar in birth weight. The recipient underwent phototherapy, IVIG, and a partial exchange transfusion, and our donor required no additional transfusions and just supportive care, and both were discharged on day of life 20. The pictures from the placenta are very interesting on this case. And so we can see that classic appearance of the TAPS placenta with those very fine and hairline vessels connecting the two territories of the twins. And when we look more closely, now in this one, the arteries are teal or blue, veins yellow and red. What was also interesting is the donor seemed to have a larger share of the placenta. And then we flipped it and looking and zooming in on these anastomoses, there were really just a few very tiny ones between and actually relatively balanced. So we were able to identify 2 small AVs from the donor to the recipient, but also 3 small AVs from the recipient to the donor. So it wasn't completely a one-way transfer uh, between the anastomoses. So that was quite interesting. And then when you flip over the placenta, you can really appreciate that difference in the appearance of the donor, which is on the right, and the recipient on the left. And in that cross section from the pathologic specimen, there was noted in the pathology report just diffuse villus edema on our donor side. So I figured I would pause if we have a minute to talk about, besides just our donor RBC size, what are the other factors that could contribute to this rapid recurrence of anemia in these cases? Because it was such a profound drop every single time. And looking at the size of the vessels, that was a little incongruent than what we would have expected.
Is it a question? Are you asking questions? Are you asking
Yes,
people?
yes.
Okay. Well, I haven't introduced the rest of the team, but obviously, I mean, the names and the pictures
Yeah.
were on the poster. So please come in. I mean, I invite obviously Professor Bashat, Enrico. We've got Professor Ahmed Shami, and also Hiba Mustafa. So please, come and join. And I plan to introduce them later, but they're very welcome to actually come in and sort of contribute to the discussion and answer your question. Um, I mean, can I just ask, why did the patient had IVIG?
They were concerned about I'm not sure exactly because this isn't an RBC, RH mediated anemia. Um, so I cannot give you a definitive answer about that.
Okay, fine. Um, so back to your question, which is about, I think, the rate of the drop, correct, of the
Right. Such
hemoglobin.
severe drop in such a short
Yeah.
time interval. If we think about TAPS typically as being a chronic disease that develops gradually over time, and then it also makes us feel a little patient when we're watching it and deciding to intervene. But then once we start, often with transfusions, then they really require those serial procedures about every week. And as we saw from Alex's data, that gradually, even if you start at a very, very low hemoglobin, progressively with each serial procedure, that hemoglobin does rise. But But in this particular case, what I thought was so interesting, it was just so rapid and so recurrent,
Yeah.
and such severe disease with very small and few anastomoses.
Yeah.
I have an idea about that.
Yeah, go ahead.
So because I looked at what the intervals are, the average intervals between transfusions, and they do tend to get longer the more transfusions you get in. And just looking at the placenta and looking at the kind of vessel connections that you have at the surface, I think the more edematous your placenta is on the donor side, the more it drives blood flow on the vessel connections on the surface to the recipient. I think it might have to do something with that. We don't quantify that very well, but the histology of those vessel connections is different from the large AV anastomosis, and that's what I would think.
Yeah. I mean, we treat most of cases with laser if we can, and the few cases that we do transfusion, they do require very frequent transfusions, almost every 2 weeks. I'm not sure why, but also I don't think that really we have any evidence or guidance. And this is one of the things, again, about the controversies and trying to get consensus. For me, this is an area where really people do it with trial and error to some extent. I don't think we have any evidence or any guidance about how often. It's not like rhesus disease where you expect the rate of the drop of the hemoglobin. And then the role of the partial excision is a whole thing, is a whole sort of, for me, black box, but I think that will be discussion. But I can see Shami. So Shami, please go ahead. So let me introduce you, or you introduce yourself, Sham.
I'm Shami. I'm a director of the Fetal Care Center at the Austin, Texas. With that said, again, is a big drop, Gina. You're right. Two things. The first is, did you check the KB at all? In these cases, that's had a big drop, and see, do we have any kind of the fetal maternal exchange? And the second thing is, I agree with Ahmed. In these TAPS group of the patient, I don't call it really edematous part of the placenta. I think, again, I work with a couple of pathologists for that part, and they do believe is an immature placenta. And the way they explain it to me is because of the severe anemia, that part of the placenta never get mature as the other side. Therefore, even if you correct it completely with even the laser or anything else, still there are some difference of the placenta when you see it at the end. But again, did you got any KB, Gina, at all?
But
The
when you
Go
do the
ahead.
laser, sorry to interrupt, but when you do laser, Shami, actually it's usually the ultrasound features with TAPS, they disappear after the laser.
That's
As
true.
well.
The ultrasound will disappear, but still, if you send the placenta to the pathology asthma, still sometimes the pathologists give you the immature placenta. That means
Okay.
the maturity of the placenta somehow is hit by severe anemia.
Interesting. Gina, you want to say something?
Oh, no, I was just going to say, for this particular case, we did not have a maternal KB, thinking about fetal maternal hemorrhage in that respect. Typically, we send a KB on the fetal blood samples as well. So it gives us another measure of suppressed erythropoiesis in the fetal samples, and also confirms the pure fetal sample on that first initial blood sample as well.
Yeah, thanks.
I think if it is edematous placenta, I mean, if we think, because that's all sort of, we're thinking about, theories here, we don't see that in rhesus. So babies who are anemic for other reasons, placenta is not always very thick. It's not as thick as what you see in TAPS. Enrico, you're gonna tell us now, because you're the placenta injection guy. So Enrico Lopriori doesn't need introduction. I think we should really rename TAPS and say it Lopriori's twin condition pathology. So tell us what you think.
Hi. Um, I was thinking about what Gina was saying about the rapid drop in hemoglobin. And for me, there is no single TAPS case that is the same as the previous one. They're all different. So there is no way of saying it usually goes like this or it usually goes like that. There are cases where you can transfuse every 2 weeks or even sometimes longer, and some cases that you have to do it much more quickly. And it depends on the type, sorry, not the type, the number probably of anastomosis and how much flow goes through each of these anastomoses. And I was trying to look at your beautiful placenta. It was nicely injected. It looked grayish, so I was wondering whether it was put in the formalin before or what was wrong with that placenta.
I am not certain if it was put in formalin before. I was not
Because then it's
present for this
difficult to inject.
injection. Hmm.
Yeah, I was not, I was trying, you could see clearly that there were tiny anastomoses, but there were
Yes.
not very clearly, I couldn't really count how many of them there were, and I could not really see the typical connections colors because you need a blue one from one side and the red
Hmm.
one from the other. But it's just to, from my point of view, the how quickly the hemoglobin drops depend on the number and the flow of blood from one to the other, which is always different, I guess.
So, but if it is this degree of heterogeneity, it makes it very difficult for people to manage, correct?
Yeah.
Because um, people need to have some guidance about what to do, and certainly the whole preparation of doing transfusion, it takes time and effort and money, correct? So, and also the expertise when you're doing the transfusion. So you do it today, I guess. How reliable is the MCA, peak systolic velocity, to monitor this pregnancy and decide when you're going to go back in? That's number one. And number two is the boost makes a difference. So when you, for example, doing recess, you use the boost after the transfusion level and with sort of the expected rate of drop of the hemoglobin to know when you're going to likely to need to do transfusion again. For TAPS, we don't know. We just sometimes, okay, we rely on ultrasound. Do we maybe do it every 2 weeks? Ahmed, please come in. Tell us what we should do.
Um, so I completely agree what Enrico says. To a certain degree, you get to know the patients as you're transfusing them, because their transfusion intervals, they can differ quite a bit. So the way that we approach that is that we plan the transfusion out, based on the closing hemoglobin, but we use the MCA peak systolic velocity as a safety net. So if the MCA goes up, then we get them in sooner, right? And I have to say we've been fairly successful with that strategy.
And that was
Okay,
also
so
very consistent in this case. The MCA would spike on that immediate examination before, and quite high, 1.7 to even 2 immediately
okay.
before. So
So it would be reasonable to rely on the MCA peak systolic velocity in deciding when is the next transfusion.
Yeah, and I mean, one of the things that's pretty staggering about TAPS donors are you could have an MCA at 1.55 MOMs and the hemoglobin is 3 or 4, right? So it provides a pretty efficient safety net. Gina, you like
yeah,
we
I would
worked
say a
together for a
safety net
while. Yeah.
too.
Okay.
But once you've decided for that next transfusion, I can't remember a case that we were sad that we went ahead, even if the MCA was reassuring, because they were always anemic again, in a TAPS case.
Okay, so are you saying that even if the MCA is reassuring, actually when you go back, the baby's still anemic?
But once you know them, right? I mean, so
Right.
the first 2 transfusions are also a learning period for the team, right? And then you get to know the patient and you say like, okay, this is what's likely going to happen. And so the third, fourth, and fifth, if you get that lot far, you know the patient.
Okay, Shami, please, you have your hand.
I
Okay.
agree with that, Ahmad. Again, comparing to the isomerization, when you compare these MCAs and you do the, first sample, the hemoglobin is much less than isomerization patients, and usually they are very severe anemic. But with that said, let me, Ahmad, ask you this question. After a couple of transfusion, how reliable will be MCA in real world?
Well, it I mean, you saw the data on the graph. I mean, there are a couple of patients where, and I think the test accuracy was like 89%. So about 11% of patients, the MCA didn't reflect the anemia. In the polycythemia, it's more accurate, but that's also because you're not correcting the polycythemia as effectively as the anemia. So part of, because if you're closing after partial exchange at 18, you're going to be back up again. So I think part of the statistics is the small numbers, and the other thing is the efficiency of the treatment.
I mean, look, I think what this discussion reflects that there are many controversies, and I think is really sort of the experience and what the evidence shows. Because, Ahmed, when we were on the NICE guideline committee and we looked at the evidence, and actually what we found that the MCA big systolic velocity in the context of TAPS was really actually had good predictive accuracy for the baby when it's baby anemic, but that was not the case for the polycythemia. That was evidence shows. Obviously, there is the experience, and there is also the partial exchange transfusion, which it seems that it doesn't really it's not as efficient, for example, as giving a transfusion. But anyway, I think there's a whole discussion, and that's really part of the controversies that we're going to discuss at the end of in the panel discussion. So I'm just conscious of the time. So shall we get Gina to come back and maybe finish her case? Please go ahead.
And so this is a case in a similar vein that we also had at Johns Hopkins, 41-year-old, 22, that presented quite early in pregnancy, 22 weeks and 6 days for TAPS as well. Also normal growth, bladders, amniotic fluid, so no concerns for TTTS. In this case, there was quite discordance of the MCA peak systolic velocity, and also that classic case of the everywhere placenta. So the placenta anterior, lateral, posterior. So this was not a good access for laser. We were concerned we would have to have a septostomy if we did go for laser. And you can see in this example, the discordance in the echogenicity between the placenta. And so in this case, although it was quite early in pregnancy, our strategy was to start with transfusion and partial exchange transfusion. And so we initially made the diagnosis of stage 2. While contemplating, thinking about this, being sure of the diagnosis, we did bring this patient back a few days later, just for complete verification, and proceeded with procedure for her. Now, for our donor, the opening hemoglobin was quite low at 3.1. Also, no signs of hydrops on this fetus. So I think that's an incredibly important point, is that these cases, likely because of its chronic nature, can have very severely low hemoglobin without hydrops. And so this patient underwent 8 transfusions and partial exchange transfusions overall with time. And pretty much before each one, we did have the spike in the MCA as well, except for one that was just borderline and the one that we were preparing for delivery at the end. Now, she did develop preeclampsia before her intended delivery timing of right around 34 weeks. And so this patient, at birth, her hemoglobin on her donor was 17. Thank you to delayed cord clamping. And for her recipient, the hemoglobin was 20. So I think I'll just stop there, because this was more of a case that kind of followed the rules that we kind of discussed and think about with exchange and partial exchange transfusion. And what was quite remarkable is the duration that we were able to extend that pregnancy with that strategy.
Okay, fantastic. Thank you very much, Gina. Any comments or questions? I mean, the partial exchange, is that, and again, from Alex data, is that obviously when we do it, it's really quite worrying, is it? Because you're taking blood and you're diluting with the saline, you're taking and diluting. But it's still in the graph that Alex showed. It's still actually every time you were going back again, if anything, the hemoglobin was going up. So is it because maybe we're not aggressive enough that maybe we should be doing more? Or is it actually it's not really necessary? And if you don't do it, how much worse would you do it? Would you make the recipient how worse this polycythemic, and what the criteria that you have in your center to do partial exchange? So if you have a case for TAPS and you decided to treat with transfusion, do you always do partial exchange? If not always, what the criteria that make you do it?
Well, even if you look at the volume that is exchanged with each of them, it's a pretty remarkable amount. I mean, that can be 50, 60 cc's. That doesn't drop the hemoglobin substantially, as in contrast to what happens with the recipient. Um, I think increasing that load on your donor without giving some relief to the recipient makes me pretty nervous. That's all. I don't know
Okay.
what you would say,
Well, but if
Ahmed,
you're
about
nervous,
that.
so can we do more? I mean, what can you exchange more? Can you become a bit like targeting, for example, to reduce the hemoglobin to within normal range?
Well, I mean, you get the biggest or decrease with that first exchange. And then after that, it's just progressively lower time by time. But also, you have to be careful because the recipient doesn't often tolerate that quite well. If you don't want to take off a huge volume, um, and then we have to be quite careful when we do that. And we're watching very closely. So
Okay. So
I'm more concerned about seeing fetal heart rate changes during the course of
yes,
that procedure with too
yes,
much volume off.
and yeah, Enrico.
I think it's true what you said, Asma, is that we don't know exactly how often we need to combine it with a partial exchange transfusion. What we do know is that if you don't do it, it can become dangerous for the recipient. There have been cases of recipients suffering from skin necrosis or such severe hyperviscosity due to all the blood that it's dangerous to do IUTs, a lot of them, without combining with a partial exchange transfusion. So we need guidance, of course, and I don't know if the MCA PSV is good enough to tell you whether or not it's necessary to do the partial, but I would warn people not to do IUTs without partial exchange, too many IUTs without partial exchange. The problem for you who are doing this procedure is that I understand they are very difficult. For us neonatologists, it's easy to do a partial exchange transfusion in a baby, but it's much more technical for you guys. I
Okay,
understand.
that's really helpful. Thank you, Enrico. Ahmed?
Yeah, I think the way that we approach it is that we always do the donor first, and then we sample the recipient. I basically, and this is really made up, if the hemoglobin is over 20, then I will do a partial exchange. If it isn't, then I would leave it alone. If I do a partial exchange, I try to pull at least 20 cc on the first aliquot, because otherwise it takes forever. And one thing I have to say is that blood really clots on the recipient. It's hard to do not it's hard to do for the cardiovascular things. If you pull a lot of volume quickly, the recipient doesn't like it, but it's actually very noticeable how thick that blood is, right? And that's how we've approached it. I don't know whether it's the right or the wrong approach, but we just had to have a rationale, like how we do it, repeatedly. And I think the MCA is helpful to say, like, well, if it's low, then you need to add minimum sample to know how polycythemic the recipient actually is. So that's kind of how we plan these procedures.
Okay, thank you. And it is honestly, it's like a try and error, because I don't think you really like it's almost, for me, it's a once you do a few cases, you're more comfortable to actually do that. But when you take the blood from the recipient and then you're watching the heart, and like you think, oh my God, it's gonna go into bradycardia, I think that can be a little bit worrying when you keep doing this, and therefore maybe we're reluctant to do large volume because we worry about the recipient. I think that's the impression. Shami.
I agree with Ahmad. That means again, nothing's again. Still, we don't know many things. But if the gestational age is lower, I usually draw less blood compared to 20 cc at the first. But the other question is, sometimes these cases will take forever. That means at what point, I mean, what is it, again, Ahmed, on the studies that you show, what is the time for exchange for the recipient?
I mean, I say for both procedures, they're typically done within an hour. I don't, yeah.
Yeah. I think it's interesting because some of the data and actually some of the like Gina's case and what also Alex presented, it seemed that you carried on and you delivered them like 34 weeks or even beyond 34 weeks, which I think many people, and correct me if I'm wrong, but that's sort of my experience, they bail out certainly after 32 weeks because of this, of like the fact every 2 weeks you have to arrange transfusion and exchange transfusion. And therefore, I think once they get to after 32 weeks, they just give steroids, magnesium sulfate, and deliver them. And what I think for me, the message there from this data, from these cases, and I know small numbers, but still, TAPS is not a very common condition, is the fact that if you have the facilities and it's technically feasible, they actually carry on so that you can prolong the pregnancy after 34 weeks, or even you had cases after 35 weeks, because perhaps it's better to actually, and it seems to be safe and to actually carry on with doing transfusion, exchange transfusion, and prolong the pregnancy.
I mean, our strategy had been to deliver time them between 32 and 34 weeks. And depending on the stability of the patient, the procedure, all those things together, we may push it a little bit closer to that 34 weeks. I don't remember a case deliberately going beyond that. I don't know if you remember any of them, Ahmed.
So the maximum would you go will be 32, 34?
Yeah. And there was one question about the delayed cord clamping I saw in the chat that it's norm. So when you know the identity of the twins at the time of delivery, so you know who is who, typically we tell our referring physicians to do delayed cord clamping on the donor, but not
the recipient, of course.
Yeah.
And I'm sure Enrico will touch on that. I know that he did a lot of work about the delayed cord clamping in monochorionic twins. I remember you give a lovely talk on it. Okay, so I think in Hiba Mustafa, so professor in Jena University, Hiba will let you unmute, yes, and then we're gonna move on to Enrico's talk.
I actually think you guys answered my question. Thank you so much, Asma. My question is for you, Ahmed and Gina. Just like Asma mentioned, at least we try to do laser if possible. So that obviously will limit us to 27, 28 weeks. So if you start transfusion then, and you aim to deliver at 34 weeks, so let's say you do transfusion 28 and 30 and 32. So these are 3 transfusions. And then I think you aim to deliver 34. What are the kind of situations that you felt like, no, I'm not going to go with laser. I'm going to go with IUT, although you were still within the gestational age that you are able to do laser. What are kind of few scenarios you would remember that you decided not to go with laser?
The most common one is the access to the equator. Since at least with the placental echogenicity and that differential, that usually gives you a really nice assessment of where you anticipate the equator to be. And so in our experience, if we were concerned that we were going to require a septostomy that would end up with functional monoamniotic twins, then we would typically favor doing a transfusion versus going for a very challenging or complicated laser. So I would say that's probably the most common scenario.
Yeah, I mean, we published before how we plan our lasers, right? And the thing is that the commonest reason not to do a laser is when you feel with your prenatal assess or your pre-procedure assessment that you cannot reliably access the entire equator by visualizing it. Then, like doing a laser, in my opinion, carries the risk that you're gonna make the disease even worse. So I have to say, so we plan it out very carefully. It's like, where's the equator? And you got to remember, those vessels are tiny, right? So the real challenge is you have to be able to see small things from edge to edge of the placenta. And that's the biggest deciding factor. against laser if you're not certain about it.
And you've never considered doing like 2 entries like we have in triplets kind of thing? You end up with equator being in both sides, no?
No. I mean, I like lasering, but I like to minimize my entries.
I mean, I think Enrico can comment, but when the TAPS registry that Enrico Labrori and his team have set up, and when the data, actually, if you look at the most fetal therapy centers, the commonest method of treatment was laser for TAPS. So I think people probably, because it's definitive treatment, correct? So you occlude it, like you correct the pathology in the first place. I think that the one thing that can be quite technically difficult when you have anterior placenta and the equator, actually you've got this quite thick placenta and you might not be able to access the periphery, and sometimes these tiny anastomoses are actually on the edges of the placenta. So that can be quite, I think, technically difficult, especially at the late gestation.
Yeah, so the TAPS registry shows that we are all doing it differently. So we all have our own preferences, and actually we probably, all of us don't know what's the best management. But laser has some pitfalls and it's difficult, as Ahmed said. IUTs are also technically difficult, and especially if you are starting already at the early gestational age, it's a long way to go. So you have to individualize and see how good you are with both procedures and decide what's best for that patient. I don't think we have the answer yet. We're doing this TAPS trial and we're waiting for those results, but it's comparing laser with IUTs, but we don't have the answer yet, I guess.
Yeah. Ahmed, and actually, funny enough, and I don't think we've ever really discussed it in this webinars, but I had a case a few weeks ago where it was MCDA twin pregnancy and also had rhesus. And I ended up actually almost relying on this anastomosis to get the blood from one twin to the other twin, because actually one twin that you could access the cord insertion easily, and the other one was very, very technically difficult to actually get to access the umbilical cord. And that was very successful. I mean, we did few transfusions, but certainly, and it's interesting how you see the rate of the change in the other twin after you transfuse the co-twin. Anyway, Ahmed.
Yeah, I just want to make a comment. So in many areas of medicine, things go to precision medicine, right? So where you individually target your treatment to the circumstances that are specific to that case. We have not adopted that mindset in fetal medicine. And to me, TAPS is actually a condition where it makes a lot of sense to approach it more that way, because the patients are individually very different. The placentas are very different, the membrane arrangement and all that. So I think we need to change a little bit how we approach. There is not one single treatment that's the better one. It can't be, not for TAPS. It might be for TTTS, but not for TAPS. I don't think it's possible.
I agree with that. And in fact, I mean, the TAPS trial, which I think is fantastic trial, we're taking part in it. And we're looking forward to obviously knowing the results. I think still the TAPS trial would answer maybe 1 or 2 questions. Is it? So it would answer in stage 2, between this gestation, whether laser is better or not, when I think technically laser is possible, because obviously if you're randomized back to laser and actually laser is not technically possible, well, the clinician will probably do what they think is technically feasible. And I suspect also if the clinician thinks this laser is not technically feasible, probably will not randomize the patient, because if the randomization is for laser and the clinician thinks that laser is not feasible. So I think the trial is fantastic, but I don't think it's going to be giving the magic solution or it's going to really answer all the questions. But Stephanie, you're going to, before we move on, please.
I'm really going to quickly say, I think this just really emphasizes the fact that we do really need more research. But secondly, one of the things that I'm seeing is that, everyone's talking about laser surgery. And I think this comes back to my point about TAPS isn't a form of TTTS. And this is something that people have in their brains. And so they go in and they ask for laser surgery. And as both Dr. Bashat and Enrico and everyone has pointed out, everyone is different and every case is different. And so we need to actually make sure that we communicate with patients that when we're treating TAPS, it's an individual process. It depends on so many factors. It's not as cut and dried as with TTS.
I mean, well said, Stephanie. But the problem that has not really been crystallized in the literature.
No.
It's not really been articulated. That's why we've been trying to do this consensus, which is proven to be difficult and challenging to get a consensus because there are many controversies about treatment, but actually that's not been articulated or published clearly to say that to give this sort of various challenging and considerations while you're actually making decisions. And also when you make a decision about the technical details of what to do, how frequent do you sample the donor first, you sample the recipient first. And this is all sort of comes with experience, I think, of seeing many cases of TAPS.
Absolutely. But I think also that is a conversation to have with patients as well, is that to simply say, we don't know what the best treatment is, but based on your situation, these are the steps we're going to take. And I think that comes back to just that shared decision-making process as well, but also really differentiating that every case is different.
Fantastic. Thank you so much. Okay, we're going to move on because this discussion can carry on forever. So Enrico Lobriori, and I said that Enrico doesn't really need an introduction. Again, Enrico has contributed a lot to this twin webinars. He's actually a neonatologist, so he's not an obstetrician and gynecologist. It's always a pleasure to have you joining us. Professor Lobriori is the professor of neonatology, is the head of the Department of Neonatology in Leiden. Leiden is the fetal therapy center for the whole Netherlands. And Enrico, obviously, when you talk about TAPS, you cannot really not know Enrico Lobriori. So please go ahead.
Thank you, Asma, and thank you for this opportunity because it's a special month or a special week because it's 20 years ago that TAPS was first described, as Stephanie reminded us. And I thought it would be nice today and a symbolic moment to not only talk about the neonatal management, but also share some slides about the history of how was it discovered and what can we learn from that discovery and the way that, we try to move on from that. So that's what I wanted to share with you. And the slides that I'm going to use are from this PhD student, now a gynecologist in our department, Lisanne Tollenaar. So all the credits go to her because she makes wonderful drawings about this TAPS disease. And this is the cover of our PhD thesis on TAPS a couple of years ago. So the first paper about TAPS was published in 2006, in March 2006, and that's why the International TAPS Day, or how do you call it, on the 3rd of March, is because that was the first publication. At that time, the group from Paris, from the group from IFIL, reported in 13% of TTS cases that were treated with laser, isolated hemoglobin discordances. And they didn't know exactly what was happening, but they just honestly reported that they were having complications after laser in TTSs. That's what everybody was seeing. But they were able to specify that one of the complications was that one baby after the laser became anemic and the other one became polycythemic. And they showed these graphs for the first time, measuring the MCA PSV as was published before. And that's the first time that people starting talking about this disease. Half a year later, we were able to describe this TAPS disease and give it a name. And it was by describing two cases which were not treated with laser. They didn't have TTTS, but they had this Twin Anaemia Polycythemia Sequence without the oligopolyhydramnios sequence that is typical of TTS. So that was the first time that TAPS was named that way, and that was the first time that the relationship was made with these tiny, minuscule anastomoses that are so characteristic of TAPS. And again, also in that paper was the first time that we discussed the typical characteristic of there being the high reticulocyte count in the donor. So the name TAPS was published in 2007, and it was chosen because it sounded nice to have a name for a disease that was in contrast with the term TOPS, which is Twin Oligopolyhydramnion Sequence. So that was why the name TAPS was chosen. And the way it went is that in Paris, but also in our department, by injecting routinely all the placentas, we started seeing a pattern. And the pattern was that in certain specific cases, there were only tiny, tiny anastomoses, like in this case where you almost cannot see it with the naked eye. You need to enlarge it to see the only single anastomosis. And this is a green to red anastomosis, and the green is an artery, and the vein is in red. So the vein is draining the blood from the donor on the right side. And that's why the placenta on the left side from the recipient looks plethoric, and the one on the right side from the donor looks pale. And that's exactly the same as the donors and the recipient were looking. The same color difference you can see on the babies are the color difference on the placenta. And we could see this in spontaneous monochorionic twins, but also in twins with TTTS that were treated with laser. It was a TTTS case, but where an anastomosis was missed. Here on the top side of the placenta, you can see one tiny anastomosis, an AV anastomosis. This time it's blue to yellow. And this AV anastomosis was making so that the donor on the left side with the blue vessels was giving blood to the recipient on the right side. And that's why the babies were looking so at birth. And in the first years, people had very many difficulties believing that only such a small anastomosis could provoke such a big problem. It took many, many efforts and many years to convince people that this tiny anastomosis was really the cause of this problem. And there were two major clues that helped us understand what was happening with TAPS. One was the repetitive pattern that we were seeing of this tiny anastomosis. And we understood from the size of the anastomosis that they were so small that the flow through these anastomosis could only be very little. And that's because of a physics law called the Poiseuille law, which says that the flow through a vessel depends on a lot of factors. The length of the vessel, the viscosity of the blood, but the most significant and most important factor is the radius. So if you have a vessel that is very, very small, then the flow through that vessel would be very low. And the other clue that helped us understand what was going on with TAPS is seeing repeatedly the same pattern that the donor twin had increased the reticulocyte count. And this is something that was previously discussed. It's always increased in the donor. Why? Because it's a chronic form of anemia. And if you have an acute anemia, for example, in acute peripartum TTTS, then you will not have increased reticulocyte count. And it's impossible to have an acute transfusion of blood through this tiny anastomosis. So a lot of these babies, before we knew about TAPS, and they were born being red and white, were termed often acute peripartum TTS. Why? Because we didn't know about TAPS, and people didn't realize that they had only this tiny anastomosis and didn't measure the reticulocyte counts. So that's a bit of the history of TAPS. Now, 20 years later, you would hope that we would know much more. We do know a little bit more, but there are still many, many things that we don't know. First thing is that many cases are still missed antenatally. And why are they missed? Well, for one thing, there is still in a lot of countries no screening for TAPS, and the screening antenatally must be done with the MCA PSV Doppler measurement. But sometimes these measurements are done, but they are false negative. So we don't recognize TAPS. And the other thing is that it's still, even if you recognize this, there are many things that are not well understood or misunderstood in TAPS. So it's good that we have these webinars. Thank you, Asma. Now, as a neonatologist, we often see these red and white babies at birth, and I often hear people saying, oh, this is TTTS. But again, as Stephanie said, we need to repeat over and over again, this is not TTTS, this is not acute peripartum TTS, you need to look forward. One of the reasons why people think more about TTS than about TAPS is, of course, it's better known, and its incidence is higher than in TAPS. So people are more aware of TTS than they are of TAPS. But the problem with TAPS is that it's really, really very different than TTS. So we need to be aware of that. One of the most important thing is that the mother, when she's pregnant of twins with TAPS, will not have any symptoms, doesn't have any symptoms. That is different in TTS. In TTS, the mother has a rapid growth of the belly, gets contractions, reduced fetal movements, shortness of breath, but there are none of these symptoms in TAPS. So if you don't look with ultrasound Doppler, you will never detect the TAPS. And that's why it's so important to use the Doppler ultrasound in TAPS to discover and detect the disease. What will you see if you do the Doppler ultrasound? If you look at the MCA PSV in the brain of the donor, you will see that it's increased in the donor and it's decreased in the recipient because of polycythemia hyperviscosity in the recipient and anemia in the donor. And if you plot the blood flow velocities in the graph, you will see that in a typical case, the MCA PSV in the recipient is low and in a donor is high, because the blood of the donor flows quickly like lemonade and the blood flow of the recipient flows slowly like in ketchup. That's how we explain it to parents. The difference again with TTTS is that we don't know what the best management is. We discussed this already. If you go in and try to cure it, treat it with laser, you have to be aware that it's technically more challenging than in TTTS, and the anastomosis will be very small and difficult to see, so it would be advisable to use the Solomon technique if you do the laser surgery. If you go in and treat them with intrauterine transfusion combined or not with the partial exchange transfusion, it's important to realize that the blood that you transfuse in the donor will immediately flow to the recipient in a different pattern, sometimes slowly, sometimes more quickly. So you will need probably to repeat this procedure over and over again. So these are two of the possible treatment, but we don't know which one is best. Now, when these babies are born and you want to make the right diagnosis at birth, it's important to do a couple of things. Not only measure the hemoglobin count, but also remember to measure the reticulocyte count. And the reticulocyte count must be measured in percentage or promillage, not in absolute value. That's a very important thing to tell your neonatologist. And if you want then to reach the correct diagnosis, you need a couple of things. You need the hemoglobin difference. It must be higher than 8 grams per deciliter. You need to measure the reticulocyte ratio, meaning the percentage of reticulocyte in the donor divided by the percentage of reticulocyte in the recipient, and that must be higher than 1.7. And if you have the possibility or you know how to inject placenta, you will find that you will have to show that there are only minuscule anastomoses smaller than a millimeter of diameter. Now, the big problem with reaching this diagnosis is that many people don't inject the diagnosis and the reticulocyte count are not measured at birth. So if you don't have these two important parameters, you will not be able to make a difference between an acute cause of intertwin transfusion at birth, we call it acute peripartum TTS, or this chronic form called TAPS. And it's important to make the difference between these two diseases because both can cause the babies to have a large discordance of hemoglobin at birth. They both look red and white. They both have a high and a low hemoglobin, but it's only in TAPS cases that you have a high reticulocyte count ratio. That's why it's important to measure that. And if you inject the placenta, only in TAPS cases you will have these few minuscule anastomoses, not in the acute peripartum TTTS. If you then flip around the placenta, like Jenny showed, you will only see in the TAPS cases this discordance in color between the part of the recipient, which is plethoric, and the part of the donor, which is very anemic. Why is it important to make the right diagnosis between acute peripartum TTS and TAPS? Well, because the management at birth is completely different. In acute peripartum TTS, the donor has an acute hypovolemic shock and needs to receive a quick saline volume bolus or red blood cell transfusion if you have that at the resuscitation ward. The recipient is often polycythemic and doesn't need further treatment. This is different in TAPS because in TAPS the donor is normovolemic. And if you give a transfusion in TAPS, you have to give it slowly. Otherwise, you can even make it worse. Don't give a quick transfusion of red blood cell in a TAPS donor because it can push him over the Frank-Starling curve where the heart is already enlarged. And also important to know that the TAPS donor has not only anemia, but also a low level of albumin, a low level of ferritin, and low glucose. The recipient twin in TAPS has often very severe polycythemia and often requires partial exchange transfusion. So it's good to make this distinction of the diagnosis because the management is different. On the long term, and that's the really important reason why we need to diagnose TAPS correctly, these TAPS survivors are at risk of impairment on the long term, and it's especially so in the donor twin. The donor twin has an 18% risk of severe neurodevelopmental impairment. And one of the reasons of this impairment is that 15% of TAPS donors have bilateral deafness. And this is something that is very important to remember because at birth, many of the babies nowadays get a hearing test, but most hearing tests are done with a test called autoacoustic emission. That's a simple test, but this will not detect the cause of deafness. This is not the right test for TAPS donor. Why? Because the deafness in TAPS donor is caused by an auditory neuropathy, and an auditory neuropathy can only be detected with an other hearing test called the brainstem evoked response audiometry, or BERA. And this is the test that you will need to do in all TAPS donors to detect the presence or not of deafness. The reason why these TAPS donors have this auditory neuropathy is not well known. Maybe it's due to the chronic fetal anemia and hypoxia, which they suffer in utero. Maybe it has to do with the low albumin. Some of these donors have albumin very, very low, lower than 15 or even 10. And we know that albumin is a very important protein that binds to bilirubin. And bilirubin is known to be toxic if it's too high for the auditory nerve. So if you don't have enough albumin, you will have a larger ratio of bilirubin albumin, which can cause this damage. And another theory is that we recently detected the severe iron deficiency in some of these donors, and that we know that iron is very important for the brain and for the nerves not only in the fetal period but also in the neonatal period. And maybe there is something else that we are not aware of. Now, to finish, I would just like to present a case just to illustrate how important it is to detect this deafness on time. This is a case that we had in 2012. and it was a case of selective fetal growth restriction. At least we thought so. It was determined to be an SFGR type 1, and at 30 weeks, this was the estimated fetal weight of these babies. Cesarean was performed due to fetal distress of the IUGR baby. When we looked back and saw the MCA PSV, at that time in 2012, we didn't call these TAPS. Why? Because only on the last measurement, the MCA of the donor or of the small one, the IUGR baby, was above 1.5. In all the other measurements, it was below 1.5. Nowadays, we don't use this cutoff to diagnose TAPS. We use the delta between the MCA PSV of the donor and the recipient. So today, we would probably have called this case a TAPS case. But at birth, that's how the babies looked like at 30 weeks. One baby was terribly, terribly anemic, and the other one was polycythemic. It had the donor an hemoglobin of 3.1 grams and hugely increased reticulocyte count, while the recipient had an hemoglobin of 19 with normal reticulocyte counts. TAPS stage 3, both had quite a severe neonatal course, and this was the placenta, typically with a plethoric part and a anemic part of the donor. And you can see on the right side, appreciate that there are only few tiny anastomoses connecting the two circulations. We did an MRI in both children, and the donor had mild white matter lesions. The autoacoustic test was normal. Again, we didn't know at the time of the presence of this auditory neuropathy, so we did not do this special BERA test. We didn't know about this problem. At 1 year of age, we saw them back, and the donor was doing quite okay. But then they left the Netherlands and went to live in Switzerland, and we only saw them years later. And when they came back, unfortunately, we heard from the parents that the donor had bilateral deafness because of this auditory neuropathy, and because of that had severe developmental speech delay. And they only diagnosed this deafness after 3 years because we didn't know about this disease. So that's why it's so important to diagnose this deafness as soon as possible, preferably at birth. To conclude, if you look at all the other complications in monochorionic twins and look at the long-term outcome, TAPS has more or less the same risk of long-term impairment, of handicaps, like in cases with TTTS. However, the difference is that in TTS, both the donor and the recipient are at equal risk of impairment, of handicap, but in TAPS, it's especially the donor that is at risk of handicap. And if we would remember to do this hearing test in all these babies, the correct hearing test, we will probably help all these donor twins to have less speech developmental delay. So I hope you remember that message. So this was my final slide. Remember in TAPS to measure not only hemoglobin, but also the reticulocyte count. Beware that there are other problems in donors, so don't measure only hemoglobin and reticulocyte, but also the albumin and the iron. And beware of deafness in donors, so perform, if possible, the BERA hearing test. I would like to thank you all for the attention, and thank also Emily and Mathilde, who often come to see us at our department, and I'm very happy that we know them and we know their mother. And thank you for your attention.
Thank you very much, Enrico. Beautiful talk as usual. And you can see that a lot of people commenting, very grateful that you give this talk. And actually for many people, still the TAPS pathology is not really fully established. And I think, you have to also step back and think, if you are working in the fetal therapy centers and you are a researcher and this is an area of interest, you live your life in this and you deal with twins all the time. But for many, many healthcare professionals out there, actually your talk was extremely valuable to understand and really go through to the pathology and the basics. So really, really grateful. Thank you very much. And maybe just to start the discussion, so we have obviously a number of fetal therapy centers here, or people working from a number of fetal, and you've seen sort of from their affiliations, at least 5 or 6 centers, both in Europe, UK, Netherlands. You've got the States, a number of therapy centers across the States. So can I just get a feeling about, number one, do you routinely tell the neonatologists that they need to do this hearing test? Enrico, do you know whether actually neonatologists across globally, I mean, I'm sure in your center you do that, but the rest of the country, if they go and deliver, they've done laser, they go back to their local hospital, they deliver the babies, do they always get a special hearing test? And in whether in John Hopkins or Austin or Riley in Indiana or, Chops, do they all have that?
Even in our center, asthma, people forget about this. So we
Okay.
need to repeat this over and over and over again. So, and I don't want to be harsh on anyone. This is a rare disease. So people have to deal, doctors, with 100 or 1,000 of diseases. So if they don't remember this, it's not strange. For us, we deal with this more often. So for us, it's normal. But even for my colleagues, some of them I work with 20 years, I still have to repeat every time what they need to do with TAPS at birth. So, and I don't blame them. But it's our task with these webinars and with other ways to educate people and educate that they need to do this hearing test. And I'm sure we miss them in the Netherlands too. I'm sure we miss them in our center, not if I'm on call, but then I need to go on holiday sometime. So
You're not allowed to go on holiday in Before. That's
Sorry.
not acceptable. So I mean, yeah, I suspect actually in the UK, probably most, neonatologists will not. And I suspect I'm not a neonatologist, but I work with them very closely. I suspect many people don't know that. And I think back again to this consensus that we're trying, and I know it's proving very challenging, but I really feel that I'm sure we can find a way to get a consensus or almost like protocol that combines both the antenatal, the fetal therapy part, and all the technical things that we discussed, as well as the neonatal, aspects of what we should be doing at birth. But one of the problems that we had when we were contributing data to the registry, Enrico, if you remember, that they were not always measuring the reticulocyte count. Right. So and therefore I think there is definitely need for it. And I know it's difficult, proven difficult because it's very controversial, but I'm sure that there is way around it. Shami, please go ahead.
Yeah, definitely from Neo side, there's a huge gap. This is what I see in the United States, and Enrico, definitely education is the key, and we need to educate people more and remind them more. But with that said, again, let me, Enrico, ask you one question. That means you show very interestingly that the albumin is very low on the donor side. Do you think at the time of the transfusion is possible that we can transfuse a little bit albumin if we figure out the albumin is low in the donor?
That's a good question. We've never done this. Usually the bilirubin is not a problem in the fetus. It becomes a problem when the baby is born. So when the babies are in the womb, they often have this low albumin, but the bilirubin is low too. So I do think that it's important to measure it at birth and transfuse it at birth. I don't think it's necessary to give it in utero. With the ferritin, it's another story with the iron. It's low also already in utero, but once you give a transfusion, then you give a lots of iron too. So if you treat them with transfusion, then once they got the transfusion, you don't need to be worried too much about the iron.
Great. Okay, Ahmed Bashat, and just maybe use the opportunity while Ahmed is commenting that there is a question about so if you start doing transfusions and you correctly identified TAPS, you correctly treated the 2 babies, does it actually improve the hearing outcome? So do you manage to reduce the risk of deafness? And it's okay to say we don't know. It's fine, but go
One
ahead.
of the things that Stephanie is working on, we don't have enough cases to know what are the risk factors and what is helping them or not. We need more cases, and that's one of the wonderful things that Stephanie is doing, connecting all these TAPS parents around the world. We can now ask them if they have a baby with a hearing problem, and then try and find out whether they had or not treatment, and whether they had a very low hemoglobin or a very low albumin, etc., etc. So we need more cases to get that sense of why some of them become deaf and others don't. We don't know that yet.
Great, Ahmed. Thank you.
I wanted to comment on one question in the chat, when to start MCA Dopplers. So I would recommend starting MCA Dopplers at 16 weeks and understanding that the reference ranges aren't great. As a rule of thumb, twice gestational age is 1.5 MOMs, and the value in gestational age is typically 1.0 MOMs. And I would do MCAs anytime you see a twin pregnancy where TAPS is a differential, or you need to explain what is going on and you're not sure, because it adds and clarifies the differential diagnosis. So there could be argument about that, but that's just my opinion. The other thing I wanted to say about the neurodevelopmental outcome in general, that is something we counsel all of our parents about, because they go back and deliver mainly in the referring centers. So it is not really up to us to institute a follow-up plan, but we talk about all of the neurodevelopmental risk, both for TAPS as well as for TDTS. And it really falls on the parents to advocate for that, how they get into those programs. So it's not great for the follow-up for like specific screening. It really is diluted out in the community where that is done.
Yes, but Ahmed, I entirely agree. And the same in the UK. The UK is even worse. But you don't think that we do have responsibility towards advocacy for these parents and these children, because you treated them during the pregnancy, correct? You operated them in utero, and as the healthcare professionals who, to some extent, responsible for their care. I mean, we could say, look, it's not. I entirely agree with you, and it's the same in the UK. We don't see these parents. They deliver, and the kids are actually not really under our care. The guidance doesn't really say that they have to be followed up.
Well,
But I just feel that if it wasn't us to advocate, who
Yeah,
will?
no. So, not that you misunderstand me. It's not that of course, we have to advocate. But the thing is, like, all of our ultrasound reports, particularly the last one, makes a detailed recommendation about all the things that should be done, including the developmental follow-up. But when the parent goes back and delivers in another institution where I have no relationship, no oversight, let alone with the neonatologists, right? Who might know everything better than we do, right? It's very difficult to enforce that. I mean, Enrico just said, even in his own unit, things are forgotten, right? So you have to constantly remind, but there needs to be some overarching professional society recommendations that this makes it a standard of care. And unfortunately, that doesn't fall into our professional group, right? We're maternal fetal medicine specialists, not neonatologists.
The problem with
Okay.
follow-up programs is that it's very expensive and a logistic nightmare. You need to be able, if you want to do it well, you need to be able to have enough people, enough on board, a psychologist, a physiotherapist, people that do the outpatient clinics that are able to see these children. And even in our tiny country, Netherlands is very small with a lot of people living in our country. People don't need to travel that much, but even in our country, it's difficult to be able to have a large percentage of follow-up, because you don't want to have a follow-up program with only 50% of people coming, because then you would have a large loss to follow up. You don't know who you're missing. And I expect that in countries like in America or in other countries where the distances are greater, it's a big challenge for parents to come back and with their children. They are in a very busy time of their life with two children growing up and giving them a lot of, I'm sure, a lot of pleasure, but also a lot of problems. So the last thing they want to do is spend a couple of hours in the car or in the train coming to a busy outpatient clinic and then go back home even more tired than before.
But can I say something? I mean, in the UK, we have a lot of problems. However, having said that, we do have really a good program that all babies, whether singleton or twins, born before 32 weeks, have a follow-up program. Okay, the follow-up, I don't know for how long, but they definitely do babies and they would follow up these children and the records are there. So we are looking at the data. But and also some hospitals, including the ones I work at, they actually follow up all the complicated monochorionic twins, not the uncomplicated, but the complicated monochorionic twins. So it is possible, it's feasible, but I'm not sure that the doctors who actually do perform this assessment are aware of the taps and the hearing and the fact that the tests that they need to be done. So to some extent, there is, at least in the UK, there is, because most of these cases are delivered before 32 weeks, correct? Unless they have laser early and they remain uncomplicated and they deliver. Still, if they had intervention, they should really, at least in our centers, they should be followed up. And if they deliver before 32 weeks, there is a system in the UK where these premature babies are followed up. But anyway, so Hiba, please go ahead.
Yeah, thank you, Asma. Actually, I wanted to kind of talk a little bit more about the hearing test from our experience. And I've seen the papers before, but I think when we started like that old consensus that we were trying to work on, and I had some exchange emails with Enrico, that's like when it kind of pushed me more to kind of go back to my institution and see, okay, what you guys are doing. So although like papers are out there, I think we need to do like better work into putting it in a different setting, into emphasizing how important this is. This is not just a research study. And so I basically did not honestly go back and see what they're doing until I had those exchange emails with Enrico. And we do have the BRA testing, but I do have some questions for you, Enrico, about it. Because since I mentioned it to them, they keep coming with questions, which is great. It's a learning process. And so my question is that, okay, so we had tabs and we did laser and it improved on ultrasound, and they're gonna do postnatal labs and they confirmed there's no tabs versus more and like, so if you can just enlighten me a little bit about what you do in your institution. Every monochorionic twins get labs, CBC, to see if they had tabs that we missed, or just those that we had antenatal diagnosis. What if they had IUTs or laser? So which one you target for this screening hearing test versus others kind of thing? That's my question.
Okay, so now we're talking about all monochorionic twins, correct, Iba? You don't want to.
Is that how you deal with all, or a subset of monochorionic twins?
So we treat them absolutely differently. They're all different groups. TAPS needs special attention for some certain things, TTTS other things, and normal monochorionic, we just don't do anything. We do measure umbilical cord blood hemoglobin. We don't do that from the babies. We just measure that from the umbilical cord blood. So there are normal monochorionic twins, 3/4 of them, which you don't need to do anything. You don't need to do hearing tests. You don't need to do anything unless, of course, if they're born preterm. The TAPS, you need to do the hearing test, the hemoglobin, the reticulocyte count, and all the other things that I discussed. And in TTS, it depends on how they've been treated. If they've been treated with laser and they've been treated successfully, because then they are like dichorionic twins. And if they go on and deliver at 32 or 36 weeks, then you don't need to do much more than that. You could measure the hemoglobin if you have doubt about the color difference, but otherwise it's only important to do those things in the laser cases that were not treated successfully. But you would probably know antenatally which one was successful and which one is not, I guess. And the same goes for, I saw some comments or questions in the chat about the delayed cord clamping. Every monochorionic twins has a different problem. We would not advise to do delayed cord clamping in normal monochorionic twins because of the danger of there being an acute intrapartum or peripartum transfusion. So we would always ask the gynecologist now to clamp the cord within 1 minute in the first baby, but that's not the case in TTS cases treated with laser. Those are just like dichorionic twins or singleton. Then if they are born preterm, we would advise them to do delayed cord clamping. Delayed cord clamping is good. And in TAPS, like Ahmed Bashat said, don't do the delayed cord clamping, absolutely not in the recipient, but it's a good idea to do it in the donor. There is no risk of acute transfusion because there are only tiny anastomoses. So every monochorionic twins has a different approach, a different management, not only in your cases antenatally, but also postnatally. The problem is most neonatologists don't even know the difference between a dichorionic twin and a monochorionic one. So there's a lot of work to do there and a lot of education, like Asma also said. They probably see these babies at the outpatient clinics without knowing what is TTS, what is TAPS, who is the donor, who is the recipient. These things are not even noted in the clinical, how do you call that, in the clinical notes. So people don't even know. You have to ask parents what they had.
Yeah, and I think, back again to Stephanie's, and Stephanie, I'm going to bring you in a second. I think a lot of people, any complication with recurrent twins was just called TTS. Because until now, most patients that you see, even the one that they referred, they would know about TTS. But when you say TAPS, I think a lot of people were just like, well, not really know what I haven't heard of. And in fact, when we had this Fern study, so through that we did a lot of studies and data and publication. A lot of actually the cases that were TTS were some of them were actually selective fetal growth restriction. So I think there is a lot of this, anything that there was difference between the two babies were called TTS. And therefore the old literature, I think, is a little bit of, some of it could be biased. Stephanie, please go ahead.
Yeah, I was actually going to say, I think like when it comes to the long-term follow-up thing, there is this persistent myth about age 2. And it still is said to a lot of people is that after age 2, everything goes okay. And we know that that's not true. And that's general in prematurity and everything like that. It's not just TAPS cases, but I'm going to share a very personal story here. And that is my donor twin was very speech delayed at age 4, even age 5. We had her in speech therapy. And roughly around her birthday, I had a conversation with Enrico and Lasagna, and they said, by the way, did you know TAPS donors are deaf? And I went, some TAPS donors are deaf. And I went, oh, well. And again, going back to my local clinic, my local hospital, having my case recorded incorrectly, we had TTS on our paperwork. And even though we were definitely TAPS, trying to get my local, the youth doctor, I guess is the easiest translation, to refer me to a secondary clinic to get a hearing test. They wouldn't do it because there was no evidence, because it was the wrong diagnosis on my paperwork. And again, going back to that, we have to make sure that the diagnosis is correctly there on paperwork. Thankfully, I kind of have a few people on speed dial, and I managed to get an appointment for an ABR hearing test in Leiden. But this is one of the big things, is that we have to really look at the language around both prematurity and also TAPS and make sure things are recorded properly.
Great. Well said, Stephanie. I think but that's also about educating parents, correct? So you have to educate the healthcare professionals, but also you have to educate the parents so that they can advocate for them. I mean, like Ahmed mentioned, the fact also the parents now need to advocate for themselves because they have very powerful voice. And Ahmed Bashat, please go ahead. Ahmed?
There's actually a comment from one of the participants, Dr. Araya, that I think is really important. So for some conditions where we know there's specific neonatal management required, we actually give our patients a fetal alert card. Gina was just texting me about that specifically for RH disease. where the baby is born with an O negative blood type because it's all transfused blood, where they still have antibodies on board and you need to follow them up that they don't get recurrent anemia and all that kind of stuff. You could actually develop an app for parents where they put in what is your diagnosis, when did you deliver, and then just basically put some things in there that they need to be aware of and seek medical attention for, right? And have you done these and those tests, right? That would be the easiest way to give parents some information that's standardized, that comes from a place that has as much evidence as possible, right? And maybe that's something that, you want to consider from the TAPS Foundation, you know what I mean? Because that's better than Google, because Google, you got to search yourself. Here you can actually load stuff in where here's a backbone of something that's relevant.
Google is now outdated. It's all ChatGPT.
No more
But
Google.
even more than ChatGPT, that there's more new AI platforms, so that patients actually almost every day there's a patient would say the question, I looked at ChatGPT and ChatGPT told me this. What do you think, doctor? Or actually, I looked at this AI platform and told me the CRL discordance was 9%, not 15% like the referral. So
I still rely on my own intelligence, because there's some questions that I could put in where the ChatGPT says, like, I'm tired now. I've actually had that. So forget about ChatGPT.
Okay. Stephanie, and then I'll tell you what we're going to do next. But Stephanie, please go ahead.
No, that's okay. I was actually the lovely Emily from the Caden Paul Foundation is actually in the comments, and she's just messaged me. And I think the app is a great idea. I think the only problem behind an app is, number one, funding. So if I can get a commitment from everyone who is in this webinar to help me fundraise and by extension, I will be more than happy to get something going on this. But obviously, obviously with research and with everything else, the biggest problem is funding. And that
Yes,
is
well, I think we have an opportunity, because obviously you've got the TAPS where, like, I know it's only in 2 days, but there is opportunity. And if we do crowdsource, we've done that before already together, and we managed to raise. Obviously, it depends how much you need. And you've got here a number of healthcare professionals where you've got the speakers who are also the pioneers in their field and active researchers and have grants. And also, the huge number of people and the delegates from all over the world that also might be willing to participate or interested in participating. So certainly we're happy to help with that, Stephanie, in whatever capacity you need. Enrico.
Yes, I'm convinced that it's easier to educate parents than to educate doctors. So I love this idea.
We're not that sick, Enrico.
Parents of TAPS, if you tell them what they need to know and they need to be aware of at birth, they are the best ones to make sure that the placenta doesn't end up in the rubbish bin, like most of the placenta, that the doctors remember to measure the right things. So if you give them, and we give the parents a small card, plastified, that can help, but an app is probably more modern and more for the current generation. But the parents are I think the key here to make sure that things go better than they are doing now. We receive quite regularly, and Stephanie surely, messages from parents. Oh, we had twins, one was red, one was white, and they asked us what happened. But if we don't have the placenta, we don't have the reticulocyte count, we don't have the hemoglobin, we cannot know. So we need to make the right diagnosis, otherwise we cannot help people.
Great. Okay, thank you very much. That was well said. Okay, I'm just conscious of the time, and we need to make a decision, because obviously a very important part of this webinar was this controversies. And as I mentioned before, and Hiba mentioned, this trying to get a consensus about these controversies. And it's really challenging for a number of reasons. And also the fact that some of the questions, I think goes down to really the monitoring and the diagnostic criteria. And we did not really, to some extent, touch on that. So I'm gonna take literally 10 minutes just to maybe set the scene for another discussion. about some of the things that I think we really still need to find a way. And even if it means that we did not reach a consensus, it's okay to say that, but we need to at least try to do a better job in that. Okay, so for the diagnostic criteria, and actually I don't want to repeat, but Enrico beautifully told us about the history of the diagnosis of TAPS, which started like the postnatal diagnostic criteria, the large inter-twin hemoglobin difference, the triglyceride count ratio, the tiny anastomosis in the placenta, and that got translated into antenatal diagnostic criteria and the initial diagnostic criteria, which is still, I think, used by many people, is the one twin with MCA peak storage velocity above 1.5 mol anemic. That's sort of for people who do scan or fetal medicine. That's the traditional cutoff for the anemia. And the recipient, which is a polycythemic peak systolic velocity less than 1 mol. So that was the initial really diagnostic criteria. And then two groups, the Dutch group and the German group, actually a few years ago, they published to say, well, what is the accuracy? How good this diagnostic criteria in identifying pregnancies complicated by TAPS? And they reported this. So actually, if I take you sort of simplify things, so with this criteria, 1.5 for the anemic and less than 1 mol for the polycythemic, the sensitivity is 46%. So you pick up only half of them. Yeah, you miss a large proportion. Specificity 100%. So it means if you find it, definitely these babies have TAPS. But if you don't find it, still you miss some cases of TAPS. And they proposed that actually we use the delta, the difference, the discordance between the MCA peak storage velocity, and they proposed a cut of 0.5 mol. And for that, the sensitivity was 83%. So you improve the sensitivity a lot from 46% to 83%. You maintain the specificity. So that sounds a better way, correct? And the German caretaker, at the same time, they published a paper. Actually, they proposed a lower cutoff. So that's a delta of 0.373 mol. And with this, you improve the sensitivity to 93%, more than 90%, but you reduce the specificity to 96%. So it's a balance, is it? So you do the lower cutoff, so you identify more of them, you improve the sensitivity, but you lose some of the specificities. And around that time, people say, well, which diagnostic criteria should we use? It's all confusing, is it? You need to speak the same language. And at that time, we did the Delphi Bashet, Professor Han Bashet, obviously was one of the experts or leaders of this. And we published that a few years ago where we developed this consensus on the diagnostic criteria. And in this consensus, people chose 1.5 mom. Still, the anemic is 1.5 mom. There's no really controversy about that. But the polycythemic, they actually went for a lower cutoff of 0.8 mom. And Enrico Labriori also was part of this Delphi. So that's a cutoff. But as we heard from Enrico, we need to move away from the cutoffs. The discordance seems to be a better way so that you don't miss cases of TAPS. And they choose cutoff of 1 mom. So that's quite a big discordance, but that was the Delphi. And perhaps because the experts also are a little bit cautious because we don't want to label every twin pregnancies have TAPS. And we, as you heard from this webinar, we don't really know what's the best treatment and the follow-up and so on. So that was the Delphi, and this is published already a few years ago. Okay, so what I did in the preparation for this is that I looked at all the guidelines that are published until recently, and I put them in this slide. And I also looked at the diagnostic criteria. And actually, all of the speakers have been sort of contributing to these guidelines, including the Americans as well. The SMF, I think there's also there's a guideline with Jena, I think, and Bashet, and maybe HIPAA and Shami also contributed to it. But if you see here, this is the guideline, the list of them: American, Assoc in the UK, where I work, ISWOG, FIGO, NICE, the Italians, Canadian, the German. And this is a recommendation of the diagnostic criteria. And what you see is that they either use the original one, the conventional one. The more recent ones do use the Delphi consensus. So the Italian use the Delphi consensus, the Assoc use the Delphi consensus. And I'll tell you a story about NICE because I was part of the committee, what they actually decided. But the American, the SMF, you use the combination of the initials of 1.5 and 1, but also acknowledging this discordance with 0.5 mol, which I showed you the data on. So you see the guidelines do vary. This is one thing. The other thing is the ultrasound features. So we heard that the diagnostic criteria really relies on the MCA peak systolic velocity, measuring it. But certainly in these pregnancies, as you also saw from the previous talks, there is have this placental dichotomy. So the anemic twin have thick echogenic placenta, and the polycythemic one have thin, dark placenta, this placental dichotomy. And the polycythemic have the starry sky appearance of the liver. So, and people, the experts start saying, well, should we include that in the diagnostic criteria? Some people said, well, maybe because it helps us, but also you say, well, but there's no really data to say how accurate and how prevalent. Do you see it in all cases of TAPS? Do we miss cases? So you can see this is sort of a lot of these controversies, and that was really highlighted when we were trying to get a consensus. So that's about the diagnostic criteria. So there'll be a discussion now. And then a few years ago, we actually looked at this diagnostic criteria. We applied our data at St. George's and looked at all the cases of TAPS and looked at the instance. So I applied this diagnostic criteria in the same cohort, like a cohort of uncomplicated monochorionic, including the referrals. And you find that the instance will vary, of course, depending on the diagnostic criteria you use. So if I use the conventional, the original one, about 8%. If I use the 0.5 mol, the delta, it's 16%. If I use the German criteria, it's 19%. That means 20%. 1 in 5 of monochorionic twin pregnancies will have TAPS. I personally think that's too high. And the Delphi was about 6%. So, and therefore, just to really show you, it's so important to get the diagnostic criteria right and being able to unify so that we speak the same language. The monitoring, which I think there were some questions about the monitoring, and just again, sort of use the opportunity, raise awareness, educate, we all educate ourselves. Is again, the ISWA guideline, which we updated last year. So January, February 2025, we updated it. And this was the monitoring protocol for monochorionic twin pregnancies. And certainly in this guideline, we said that we should do it for all monochorionic twin pregnancies from 20 weeks, that we should be measuring the MCA peak systolic velocity. Is that consistent with the guidelines? No. In fact, the NICE guideline, and this is all, we had a long discussion about TAPS. We didn't actually say, well, no, we don't really know what's the best treatment. In fact, actually, the MCA peak systolic velocity, it was good for anemia, but it wasn't really very good for polycythemia, so they didn't want to. They said we only do it in complicated twin pregnancies. So the one that have laser, and then there's maybe both laser TAPS, all of them, and the one that have anything that's deviation from normal. So if they have selective fetal constriction, if they had isolated polyhydramnias or unexplained polyhydramnias, if they have any evidence of cardiac dysfunction, cardiomegaly, hydrops, abnormal Dopplers, all of this, you need to do peak systolic velocity weekly from as early as 16 weeks because you're looking for TAPS. So they really limited the recommendation to the complicated monochorionic twin pregnancies. The other thing, which I think, again, I see it a lot in my clinical practice and from the referring unit, that sometimes you have initial diagnosis. If you use, let's say, for example, the 0.5 mol discordance, and then you follow up this pregnancy in a week, and the MCA is back to normal. And again, as we published this a few years ago, when we looked at TAPS, whether spontaneous or post-laser TAPS, a proportion of them, about 10%, actually are stable. They don't progress. And about 40% regress. And some of them require immediate intervention, and some of them, they progress. So not all the cases that were referred as TAPS or identified using this diagnostic criteria actually progress. Some of them get better by themselves spontaneously. So again, if you look at the guidelines that are published and look at the recommendation about monitoring of TAPS, and this is the same list of the guidelines that I showed you earlier, and you see that almost all of them now, they recommend that we should be looking for TAPS in all monochorionic twins So, and therefore things have moved. Now people are talking about that we should be looking routinely. The Americans from 16 weeks, the RSOG in the UK from 20 weeks. That is what we said from 20 weeks, I showed you. FIGO is a bit out of date and we're going to update it soon. The NICE guideline, I told you, only complicated ones, but from as early as 16 weeks. The Italian said yes, they did not specify from what gestational age. The Canadian, yes, all of them from 16 weeks. The German, all of them from 20 weeks. So you can see actually almost all the guidelines say that we should be looking for TAPS in all monochorionic twin pregnancies. And this is the RSOG guideline, which was only published like last year, I think. And they said from 16 weeks that we should be looking at MCA peak systolic velocity. I think the staging is another huge dilemma, because the staging, when you say about stage 2 TAPS, for example, are we talking about the same staging? So for example, this antenatal staging, which is the original one, let's say stage 2, 1.7 and 0.8 mom, that's what the German and the Italian, I think, are recommending, and the Canadian. But actually, there is also that the Leiden team have proposed different classification of staging based on the discordance. So stage 1, 0.5, stage 2, 0.7 mom. So again, there's a problem, is it? Because when you say about stage 2 TAPS, what do you mean by stage 2 TAPS? Because it depends which classification, which staging you use. So I think it's and again, this is SMF and Jena, I think you're the leading author for that. For stage 2, according to this guidance, is 1.7 and 0.8. But we did not really specify, I think, the cutoff for the discordance in MCA peak systolic velocity. So, and again, the Italian have different ones. So, because it depends which diagnostic criteria and which staging. So I just want to really to highlight that the fact that there are different diagnostic criteria, there's different classification of staging, and therefore there is a need to actually reach a consensus. The management, which I think we spent some time, of course, talking about the management and the various options of management, whether the expectant management in mild cases with a preterm delivery, for example, if it's after 32 weeks, laser, the blood transfusion plus partial exchange, or selective termination, for example, using cord occlusion in selected cases. So again, I'm not going to go really sort of repeat the data. I think Enrico did take us through that, so I'm going to stop here. And then highlighting the TAPS trial, which again Enrico mentioned, that stage 2 TAPS randomized is a laser surgery or whatever sort of the standard management between 20 and 28 weeks. Randomized is a laser standard management, and this is an ongoing trial. The individualized management, which I think we did touch on it, and I think, Pashat, I would love to hear your comment on it, is that how do we actually articulate that in a guidance or in a consensus? Because it is true that when you see a patient, it's not just the question about laser versus transfusion. It's about the gestational age that you need to take into account, whether there's any evidence of compromise, other abnormalities in the Doppler, for example, and whether it's spontaneous or post-laser, and if it's post-laser, technically it's feasible or not. And then the other thing which we never really spoke about is the speed of Doppler progression. You see a TAPS, which is completely stable over a few weeks, and you see a case that you see it today, next week, the measurements are getting much worse, and the following week, you're already starting seeing signs of hydrops or cardiac compromise. And then for many people in the webinar, the availability of fetal therapy, and whether actually how easy it is to access someone who will do laser or do a transfusion. So again, just as an example for the effect of the gestational age when you take into account, if it is before 26 weeks, well, we discuss whether we do laser is technically feasible or transfusion. Between 26 and 30 weeks, it's probably similar, but I would say most people would consider transfusion because maybe laser is more technically difficult and more risky. But what about after that? After 32 weeks, I think most people will consider delivery depending on the severity. So really just to maybe introduce the idea of actually being able to have individualized management and that being able to translate it or include it in a consensus document. So I'm going to stop here, but I will want really to start the discussion about some of the things that I sort of highlighted in this. I'm going to stop here because of the time. Okay, Gina starts, please. Go ahead.
Thank you so much for sharing that. I agree with you in your representation of how we think about it, and I love algorithms. When I think about, we think about a complicated patient, which things send us down this direction. So when I consider how could we represent that individualized and personalized care within, an advisory document, then I can think about which would send me down this pathway in particular. And I can just share one view of an algorithm we had made within NAFTNet, actually, and shared with the group that they recently published kind of their response to the SMFM guideline. So let's
Go ahead.
see. Do you
I think
see?
one thing that we would really want to from this discussion is to be able to really get a consensus. I mean, I know we tried and it was difficult. And I think there will be certain things that we will not reach consensus. And diagnostic criteria, I think, needs to be supported by data, by evidence. But these algorithms, I think we need to really try to find a way. And yes, of course, each case is different and there'll be individualized management, but I think it would be great to just really articulate that and have it available in the literature. So please go ahead, Jen.
Right. So is it sharing right now?
Yes, perfect.
Okay, perfect. So in thinking about, and trying to put into algorithm of how we approach TAPs and how we manage them, at least within our group at Johns Hopkins, was really represented by this, that once you see that discordance or you identify it and it increases your suspicion, then that changes our frequency of surveillance and that we step up that surveillance. And if there's signs of progression, depending on gestational age, kind of guides what are our choices. When, again, to step up that weekly surveillance if you decide to intervene it or not. And finally, ending with your culmination of delivery between those 32 and 34 weeks. And so this was adapted in the publication that came out of a working group from NAFTNet to help kind of guide when we think about the individualized management for patients.
Okay, fantastic. Thank you very much. That's really helpful. And thank you for sharing. And in fact, I mean, I said because of the time I stopped, but I had quite a few slides about, the different sort of stages and how often should you repeat the scan and the threshold for intervention, and maybe when should we deliver and how would you deliver. So I think that's something like that. Yes, it might not be perfect, but at least better than nothing, because at the moment we don't have anything. Gina, is there another comment, or you still have your hands up?
I'm good,
Oh,
thank
no,
you.
it's a legacy one. Okay, Stephanie, please go ahead.
My actual thought is like we talk about TAPS as a rare disease, and having been part of the advocacy for getting TAPS and orphan code, it is a rare disease. But we talk about it being a lower incidence than TTS, but is the lower incidence of TAPS really because it's rarer, or because there's a lack of screening and a lack of consensus? And this is really one of the things that it should be talked about as well, is that we have to be consistent in how we talk about it and get consistency in screening, because I don't think it's as rare as we think it is.
I showed you the incidence based on the diagnostic criteria.
Yeah.
Which one you use. So yeah, it wasn't rare when you go just for the discordance, and the lower the cutoff for the discordance, actually, the more common it was. Hiba.
Thank you so much. Yeah, I can kind of fill in a little bit from the discussions we had as a group in the consensus. One of them I wanted to mention the placental echogenicity and the liver changes we see in the recipient on imaging. And there was a few people who were very advocate for this. But the concern that came from that standpoint from other experts is that this is more of a subjective finding, not objective, and how well you can actually see it, how often you can actually see it. This is more adding pressure maybe to the referring providers. So what if they don't see it? What if they see it? Do we rely on people actually identifying it if we use it as a screening or diagnostic criteria? That was one very important part of the discussion that came. And also the individualized management, which we all, I think we agree today that it's individualized. But part of it as well, because this is a surgical management, and to be able to do a certain technique, it varies per pregnancy, to be able to do the expertise, access, like Ahmed mentioned, finding the equator. And that's also kind of part of why it's individualized. It was really hard for us to kind of come up with a certain management versus another. But one thing I was very much advocating for is that, okay, so the patient will make it to the fetal center, and most of people who work within the fetal center are experienced enough to deal with this. But what about the referring provider? How can we give them enough support into when to refer a patient? And that's what screening and diagnosis and stage 1 comes into play, because we rely on referring providers to identify those pregnancies and send them to us. But prior to patient makes it to our center, they are really not. We don't follow every monochorionic twin. So how can we give a better guidance for referring providers? Okay, if you see this, then send her to a fetal center. And that's kind of where the discrepancy came. Do I use a cutoff? Do I use less than, more that? Do I use placenta? Do I use liver, etc.? That was kind of a big debate, I would say.
Yes, I know, but I think this if you look at the literature and the data, the diagnostic accuracy for diagnostic criteria, I think they didn't have any of the ultrasound features. Maybe it's good, maybe it's present everywhere, but we just don't know whether it can be actually incorporated as a diagnostic criteria. Yes, we all see it, but do you see it in all cases? And is it feasible enough on all cases? Like if you have 30 weeks monochorionic twin pregnancy with a posterior placenta, how feasible it to look at the placenta dichotomy? So I think, and therefore I'm not sure that we can include in diagnostic criteria unless you do have the data to back that up in terms of how accurate it is, how feasible it is. Ahmed, please go ahead.
So one thing that has hurt the consensus in TAPS is because we're translating a lot of things that we learned from TTTS, even the staging. I mean, the staging is just an adaptation, like stages 3 and 4 from TTTS, right? And to a certain degree, it's a little bit of nonsense, actually. So the first thing you got to say is like, what is actually the gold standard of diagnosis? It's not the discordance. You sample one baby, it's anemic. You sample the other one, it's polycythemic, right? That is the gold standard. We have never compared all of these staging criteria in exactly predicting that discordance at the time of sampling, right? So it's the discussion mixes up a little bit. What's the prevalence of these kind of abnormalities in the population, and these and these and these and these? I think what is safe to say, if somebody's got MCA discordance, then they need to be evaluated. And it's safer to have a wider safety net that has a high sensitivity and a low specificity, because you don't want to miss somebody. Who needs treatment and what treatment? That's a secondary discussion that will be, that would have to be based on a gold diagnostic standard that is objective, which we haven't defined yet. You know what I mean? So getting consensus is a little bit difficult in that sort of setup where we currently are at.
Yeah, and entirely agree with you. And that's why I think, so I haven't given up completely on it. I think we need to redirect. So there are certain things which we just cannot get consensus. And I think we need to really define what would be in clinical practice for the screening, for the monitoring. And then when you get to the fetal therapy center, there's a sort of a different management and different the monitoring. But certainly some of this. So for example, after you do laser for TTTS, if 1 week and there is discordance in the MCA, would you act on it? We don't. We wait until we see her the following week. And many of these cases, actually, the MCA could go back to normal. So I think this is a lot of the things, it needs to be just have a clinical angle to it, and also not being shy from saying, well, there's no consensus, because people do different things, and you could do this, you could do that.
Spontaneous TAPS is a different disease than post.
Correct. But that needs to be also defined and refined, because unless people, when we wrote the ISWA guideline, Ahmed, obviously the TAPS was a small section because the guideline covered the whole twins, so it's a massive scope. But actually, what we really need is to produce a similar document that's focusing on TAPS, to that level of the details that we actually went through. Because otherwise, I don't think there's anything, correct? I mean, the SMF obviously have, to some extent, you've done that in your document. I think it's fantastic document, but I think it's still there are sort of some controversies about it, I think. Okay, Stephanie.
I do think that we absolutely need to have this consensus, but I think and also need to have a lot more cooperation, collaboration, and data sharing between centers. And because if we're not collecting the same data and we're not cooperating together and we're all not working together, we are still going to have this patchwork. And what we really need to do is have this international collaboration, people collecting the same data, because we saw this with the TAPS registry. And Enrico mentioned it earlier. Everyone had different data, and they had different ways of doing things. We need to have a consensus, then we can test it. And I think that's a really important part of this.
Well said, Stephanie. You're all giving these words of wisdom and giving us direction how to move forward, which is brilliant. Thank you very much. So Hiba, last comment, and then we have to, because this webinar is usually about maybe an hour and a half, 2 hours. Today, we almost come into 3 hours. We have to draw the line at some point. So Hiba, you've got the last comment. No, now you talk.
One last thing I wanted to mention is that one question came up, who should be part of this consensus, right? Like how much cases you see that you can qualify as I know everything, I know most about TAPS. I mean, you do hundreds of cases, and then Ahmed just published a paper and we learned a new thing, and people keep publishing. So who should really be involved? Who counts as an expert? So this is a very important question, also came up through the discussion, and that threw the Delphi away from reaching that consensus too, that I wanted to kind of mention.
Yes, that's something also. Yes. Yeah. I mean, it's difficult to say because TAPS, I mean, to be honest, I think if you're working in a fetal therapy center and that sees like monochorionic twins, I think this is probably as good as it gets because there's no one center that see the TAPS cases. I think these cases get sent to the same center that TAPS will get into, the TTS cases we get to. So, and therefore, I think, experts obviously there are well-defined criteria that we use in terms of publication, in terms of being sort of your clinical experience and how the volume of cases that you see. And TAPS, because the numbers are not that many, probably Stephanie, because we miss a lot of them, I suspect, rather than it's a rare disease. But I think if you apply the same criteria, even if you have a smaller numbers, I think having a small number of people who are really engaged and sort of really aware of the literature, I think it's better than having hundreds of people who are not engaged and not really have the in-depth interest and knowledge. I hope that's sort of helpful. Okay, anything else that we need to say before? Just there's one question that I've seen, and it was in the subsequent slides, but I stopped because I really wanted the discussion more than actually giving a talk. It's about the CTG. So this baby is certainly when they are viable. So for example, we in our center after 26 weeks, we would do CTG for them. And certainly if the CTG is very abnormal at a gestation where you consider delivery, fine, unless you have intervention. So for example, one case at spontaneous TAPS that was referred, I think at 30 weeks, and I was on call, and already by the time she arrived, the CTG was very abnormal. So we're don't have enough time to do a transfusion, or you're not going to do laser at 30 weeks. So we actually give steroids, magnesium sulfate, and deliver the babies. The babies did well. So, and therefore the question about the CTG, yes, I think that obviously part of your practice. And if it's abnormal, depending on the gestation, depends on abnormality, you would consider threshold for delivery. Anything else? Okay, well, I'm going to stop, but thank you very much. Huge, huge, huge thanks to all the people who actually joined us today, and particularly my amazing experts from all over the world. As I said, it's a Sunday, it's a different time zones, and people came together because they really want to share the experience, share the knowledge, improve the outcomes for babies. And Stephanie, we love you because we love your efforts, and thank you very much for driving the agenda about TAPS and all of your advocacy work. And we will do our best about the app. Anything else? Great. Thank you very much. Just to remind everyone, this webinar is recorded. It's available. It's free. We'll put it on the TAPS Foundation website as well. And just a really huge thanks to my team. They work really hard behind the scenes to make these webinars available, and they run efficiently. So I'm very, very grateful. Thank you very much, guys. Enjoy the rest of the weekend.